Good morning. If you'd be kind enough to move to your seats, we're going to get started this morning for our final day of the meeting. Let me see if we have some, just to remind you, this is jointly, we get CME credit from the Medical Education Resources and the Southern California Society of GI. So we thank our sponsors, Gilead and Salix, for support. Today's program this morning, we're going to start off with two titled lectures, and then we're going to go on to have a panel discussion thereafter. We have any announcements? Let me see if we have any announcements. These are your symposium chairmen. As you know, I'm Dr. Pokris. These are our faculty today. And the learning objectives I don't have to go over. Let's see what else we have here. Anything interesting? So to get your credit at the end, you have to take the post-test. So remember, you took a test before we started. We want you to take it again at the end. And this is just to remind you, I'm going to promote this. The Global Hepatitis Summit meeting will be held in Los Angeles this year. So that's an honor. It's put on by John Ward and Nora Turalt, and that normally is in Europe or Asia. So it's a chance if you're so interested in participating. So we're going to start this morning with the Telfer B. Reynolds lecture. I trained with Telfer Reynolds, as did many of us over the years. He was a king of portal hypertension and liver disease and a wonderful man. And there's no better speaker in the world, really, than Lupe Garcia-Tal to give us an update. She's done this for us before and really changed the paradigm in how we manage portal hypertension over the years. Lupe is still at Yale, and hopefully we can convince her to stay there. She's also the chair of the Bovino Corporation. I didn't know that. And she's an associate editor of New England Journal of Medicine, so she wears a lot of hats and she's very busy. And Lupe is here this morning to update us on portal hypertension. Well, welcome, Doctor.
So thank you so much, Paul, and for having invited me to give this lecture. It's really an honor because, like I'll say in some minutes, Pete Reynolds was like really an icon for me, someone that I looked up to. And I have no disclosures. And so Pete Reynolds was a clinical investigator par excellence. He didn't want to do any basic research. He wanted to find out how to investigate and treat patients with portal hypertension. That's what and he lived from 1929 to 2004. And there was an obituary published in Hepatology by Tom Boyer, who has also unfortunately passed, was another one of my great colleagues and heroes. And he said this, a clinical investigator par excellence. And if you think about what I do with portal hypertension and measuring portal pressure, as I'll show you in my talk, he published these papers like back in that, I wasn't even born, right? About comparing wedge hepatic vein pressure with portal vein pressures in human subject with cirrhosis. And he would do I'm going to say, I'm sorry. I'm going to signal on this screen here. And he did the studies where you do the wedge. So you put a catheter in the hepatic vein, you wedge it, and you have a high pressure. And then and he said this very interesting, when you withdrew the catheter, it would drop immediately because now you're getting the hepatic vein versus the sinusoidal pressure. And this is what we call the HVPG, the hepatic venous pressure gradient, which is what most of my research has been based on. So I'm really, I'm sorry? Well, yeah, well, no. Let's not go crazy. No, we try not to do something as invasive. So this was minimally invasive. You're actually, because the portal vein, imagine, is in between two capillary beds, the sinusoids and the splenic capillary. So the only way to get there is like really being very invasive through the spleen or through the liver. But they found this way of doing it just where you just catheterize the hepatic vein and it's going to be less invasive. But anyhow, so this is what I'm going to talk about. And portal hypertension is defined as an increase in pressure in any segment of the portal vein. So just so you know where we're located when I give this lecture, you have the pre-hepatic, like you would with portal vein thrombosis, in which case you would only have this part here that's going to be hypertensive. The sinusoids, all this are going to be totally normotensive. Then you going forward, you got the pre-sinusoidal, and this is in the sinus, like schistosomiasis, where the eggs of the bug get stuck there. But now we have this entity, it's a new entity that's called portal sinusoidal vascular disorder, and that includes NRH, and that is something that's now being renamed and reinvestigated. Is a huge area now of investigation. Then you have sinusoidal, where the problem is in the hepatic sinus, a liver disease per se, that is cirrhosis. But then we also have post-sinusoidal, that's the sinusoidal obstruction syndrome, or what would used to be called veno-occlusive disease. And then finally you get the post-hepatic, where you have a thrombus in the hepatic veins, like Budd-Chiari syndrome. But by far, the most common type of portal hypertension is sinusoidal due to cirrhosis. And this is, like I said, intrahepatic. So there's a high pressure in the sinusoids. So what is cirrhosis? Is the end stage of any chronic liver disease. You'll get a cirrhotic liver. And as you can see, they're totally different. The normal liver is nice and red and smooth. The cirrhotic liver is yellow and bumpy, lumpy. So if we could see, we could make the diagnosis just by looking. And in fact, when a patient has had a surgery recently, you ask the surgeon, what did the liver look like? Because that is the ultimate way to diagnose cirrhosis. Any chronic liver disease, and currently mast cell, alcohol, and ALD are the most common. Incredibly, we're talking with Dr. Pockers right now, hepatitis C and B, we're talking of them like a minor cause of cirrhosis now when it used to be like a number one. So this is actually pretty amazing. Normal liver is soft. Cirrhotic liver is hard. Just so we think about liver stiffness measurement, that's what we have to talk about. And of course, the gold standard in the diagnosis is still histology, even though you're getting a teeny weeny little piece. Stage 0, there's no fibrosis. F1, you have just periportal fibrosis. F2, there's a little stranding coming out of the portal space. Stage 3, you already have bridging, and there's sort of like this certain nodularity. Stage 4, you have nodules that are surrounded by fibrous tissue, but these are regenerative nodules. They don't have a central vein. So these are the ones, it's very difficult sometimes to tell between F3 and F4. So we call this advanced fibrosis and cirrhosis. So when you say advanced fibrosis and cirrhosis, it assumes that you have done a liver biopsy. But now, and the deal breaker in any chronic liver disease is whether the patient has cirrhosis or not. Hepatitis C, mortality only was increased in patients with cirrhosis, and same for mast cell, right? Look, this is a paper by in the New England Journal of Medicine. Your mortality is sort of intermediate F3, but the highest mortality occurs when the patient has cirrhosis. So when you see a patient with chronic liver disease, the first question in your mind is, does this patient have cirrhosis or not? Because this is the deal breaker. And you can do liver biopsy, like I said, it's a histological diagnosis. I hate doing liver biopsies, but you go there, you see the histology. But like I said, the liver is hard, and we now have liver stiffness measurement. And if you have a liver stiffness of more than 15, we have something that is called CACLD, which is compensated advanced chronic liver disease, which is the elastographic way of diagnosing cirrhosis. When you hear CACLD, we talk about CACLD, it means that their liver is very stiff. You don't have a biopsy, but you are pretty sure that this patient has cirrhosis, all right? And like I said, this is entirely non-invasive. The way this was invented was because people in France had cheeses and they wanted to figure out how mature the cheese was, that they could open it, and they had this thing that sends a vibration and it comes back and tells you how stiff the cheese, and in this case the big cheese, which is the liver, would you can diagnose it that way. And again, now once you have cirrhosis, the deal breaker is whether the patient is compensated or decompensated. This is a 10-year timeline, and you can see that as long as the patient, even with cirrhosis, is compensated, the median survival exceeds 15 years. Whereas once the patient develops any decompensating event, and we'll talk about this. The median survival goes down to 2 years. Less than 10% of the patient will be alive in 10 years. So the transition from compensated to decompensated is about 10% per year. But this is like, again, the deal breaker in a patient with cirrhosis. And what is decompensation? Decompensating events come mostly from having portal hypertension, sinusoidal portal hypertension. You get varices, these open up and bleed. Variceal hemorrhage is one of the decompensating events. Then you also have a hyperdynamic circulation. You have an increase in pressure in the sinus, so fluid leaks out into the abdomen, that is ascites. Then you have shunting, that shunts ammonia away from the liver into the systemic circulation, you get encephalopathy. Liver insufficiency is the second syndrome that comes from having cirrhosis. And in this case, then you will not be metabolizing the ammonia, for example, and that contributes to encephalopathy. But jaundice is a complication that is solely due almost to liver insufficiency. So, but most of them important complications, the most common by far are variceal hemorrhage and ascites, come from having portal hypertension. And for many years, right, like, we're talking 20, 25 years, more than that, we're obsessed with variceal hemorrhage, because clearly it's not the most common complication. Ascites is the most common, but it's the most dramatic. And we were like terrified of variceal hemorrhage. So we wanted to prevent even varices from occurring. So this was the timolol study. This was a seminal study. It was in the New England Journal of Medicine. It was funded by the NIH, and what we found here was that patients with compensated cirrhosis, we included patients with compensated cirrhosis, HVPG of more than 6, which defines portal hypertension, and who had no varices. And the primary endpoint is to see if we could prevent varices from occurring. It was an entirely negative study. But the only advantage was, so timolol, which is a non-selective beta, we use timolol. And that's why we call this the timolol trial, because the company gave us the beta blocker for free. So it's exactly the same as propanol, only this is a timolol trial. And it was negative study, but what the advantage that we had is we had measured the HVPG. So we knew what the portal pressure was. And so you can see here that those that had more than 10 were less likely to remain free of varices than those who had a baseline HVPG of less than that. So we found a cutoff, normal is 3 to 5. So if you had less than 6 to 10, you were less likely to develop varices than someone who had more than 10. And then we questioned, this is varices, sort of lame, it's just varices. It's not, you cannot see them clinically. And we thought, so this, first of all, led to the concept of risk stratification. So not all cirrhosis patients are the same, but this was our seminal study. This was a post hoc analysis of the timolol study, where we looked at the patients later on when they developed decompensation. So ascites, overt ascites, variceal hemorrhage, or overt encephalopathy. And these were the outcomes in this post hoc study. And we found that exactly the same thing that had happened for varices. Patients who had 6 to 10 had a less likely possibility of developing decompensation compared to those who had more than 10. So now we know that we call this base HVPG of more than 10, we call it clinically significant portal hypertension. So strictly, when we say CSPH, we're talking about someone who measured the HVPG. And of course, the others had mild HV. And this was confirmed recently in a big cohort in the simtuzumab trial. They were all patients with MASH compensated cirrhosis, and the same thing happened. HVPG more than 10 were less likely to be free of this is survival actually, but it also included decompensation. And so they had these were the decompensating events. They had not only varices and decompensation, but they also had mild increases in death. So HVPG more than 10, clinically significant portal hypertension. But you're not going to be measuring this. This is a nuanced test. And this is what I was telling you about, that Pete Reynolds started doing this. You put a catheter through the jugular vein. It goes through the heart into the liver. You wedge it, or we inflate a balloon and deflate it. You get the wedge and the free, and you subtract that, and you get the HVPG. And CSPH is HVPG more than 10. However, it's nuanced. Not anybody can do it. Radiologists don't know how to do it unless you're there with them and telling them and getting a recording of it. The other thing that is sufficient to diagnose CSPH is the patient has varices or collaterals on imaging. The fact that they have varices, you don't have to measure any pressure. It means that the pressure got high enough that is more than 10 that they have CSPH, all right? So that's one. But the other one is you can also look at it by looking at the liver stiffness. So more than 15 is cirrhosis, but you have more than 25, irrespective of the platelet count, that diagnoses CSPH. If they have a liver stiffness of 20 to 25 and a platelet count less than 150, or liver stiffness 15 to 20 with a platelet count of less than 110, these are all criteria that will make the diagnosis of CSPH. And why do you want to make a diagnosis of CSPH? We make it if we can prevent. We're identifying a group that is a high risk of decompensating, and we can prevent decompensation. And this is how it works. So you have increased resistance, right? This leads to mild portal hypertension, but at the same time, there's already splanchnic vasodilation. This leads to increased flow into the portal system. The pressure increases to a CSPH level, and it's only then that these collaterals open up, right? But at the same time, this vasodilatation leads to effective hypovolemia that activates neurohumoral systems, renin-angiotensin, aldosterone, and so forth, sodium and water retention, a relative hypervolemia that increases flow, increases cardiac output, so you're increasing the flow as well. So it's a vicious cycle. Not only that, this activation of neurohumoral systems, these are vasoconstrictive systems, we think go into the liver and cause vasoconstriction. So it's clearly a vicious cycle. And once this vicious cycle occurs and the patient is already retaining sodium, it has a high pressure in the sinuses, you get ascites formation, flow through the varices increases, the varices rupture, and if you have a lot of shunting, you'll get encephalopathy. So this is like the three main, and clearly variceal hemorrhage and ascites all result from having CSPH, right? So how can we can now stratify patients. So it's compensated. It doesn't just go to decompensated. If they do not have CSPH, you don't want to do anything because they're not at risk of decompensated, but you want to work on the etiology because you're hoping that you will prevent CSPH from occurring and you will actually transition to a non-cirrhotic stage, which is our hope. We're now working at seeing if there's regression of fibrosis and so forth. But if the patient has CSPH, they are at high risk of decompensating. So you want to stop that from occurring by lowering the pressure. And how do we do that? By using non-selective beta blockers. And this is how it works. This is how non-selective beta blockers would work. They work on the increased flow. So propranolol, they're non-selective. So the beta-1 blockade decreases cardiac output, but the beta-2 blockade, and these are experiments from Dr. Grossman's lab, who was my mentor, beta-2 blockade causes splanchnic vasoconstriction. So both effects, so you need a non-selective beta blocker because you need both the beta-1 and the beta-2 effect. Now, carvedilol is a very particular type of beta blocker that in addition to having these beta-1 and beta-2 blockade effects, actually has an alpha-1 adrenergic blockade that we think causes vasodilation inside the liver and therefore decreases resistance. So it will have a more potent effect. And in fact, can they, and the question was, there are studies that do show that carvedilol lowers portal pressure more than propranolol. So these are studies that show that actually these are in patients with compensated cirrhosis, a decrease in HVPG. These are what we call responders that had a decrease in HVPG more than 10% or to less than 12. You can see here that they had less decompensating events, ascites, variceal hemorrhage, than those who were non-responders to beta blockers, right? But the ultimate trial that shows this is the PREDESCI trial. This was a multi-center Spanish trial that was published right at the end of the pandemic. And you can and as opposed to other trials, the main objective was to prevent clinical decompensation, all right? And these were all patients that were compensated, super compensated. They had CSPH, so they measured the HVPG in all of the patients. They had more than 20, and they had no or small varices. They could not include patients with large varices because our recommendation at this point was to treat them with beta blockers, and you could not randomize them to a placebo. So these are the main results. The beta blockers clearly significantly decrease decompensation. This is a hazard ratio of 51, meaning they decreased by 49%. And these were the outcomes: ascites, variceal hemorrhage, and encephalopathy. The primary endpoint occurred in 16% in the beta blocker group, 16% decompensation versus 27% in the placebo group. This is an absolute risk reduction of 11%. So you need to treat only 9 patients to get 1 prevention in 3 years, which is better than what you get with blood pressure lowering drugs for cardiovascular events. So clearly a super impressive event. And if you see the actual clinical features that were prevented, ascites was the one, because it's the most common, was the one that was prevented. It's something that prevents ascites, which for me is like the worst event. There was a tendency, of course, for remember, these were all no or small varices, so they also prevented the development of large varices or varices with red signs. That was not significant, but it was a tendency. And there was also a tendency for a lower mortality. The study was not powered for mortality, but the tendency is in the correct direction. So based on this, Baveno 7 concluded that beta blockers should be considered to prevent decompensation in patients with CSPH. We're not talking about varices, we're talking clinical decompensation. So which beta blocker? In this study, 2/3 got propranolol, 1/3 got carvedilol. And this is a meta-analysis of comparing carvedilol versus any other beta blocker, mostly propranolol, in terms of reducing portal pressure. And you can see here that there was a significant reduction in portal pressure related to carvedilol. And not only that, in other studies that compare carvedilol with decompensation or death, carvedilol had a better effect than any other therapy. So carvedilol, so based on this, the ASLD guidance that just got published earlier this year says that carvedilol is recommended as the preferred non-selective beta blocker for the treatment of portal hypertension. And the way you started is we wanted around 6.25 to 12.5 milligrams a day. You started at 6.25. I actually started at 3.125 at bedtime, and then you start increasing the dose. You basically, again, as you do for propranolol with heart rate, but the maintenance dosage can be given as a single dose, as they did in the PREDESCI trial. So we have had a major paradigm shift, right? All paradigm compensates. First, we do an endoscopy. We're obsessed with varices. If they had moderate to large varices, we did beta blockers, or we would ligate the varices. If they have small varices, we could or not give them beta blockers. And if there are no varices, we just endoscopy every 2 years. The new paradigm, we're not doing biopsy or anything, we're doing cackle. We're saying this patient has cirrhosis. If we look at what the liver stiffness in their platelet count. If they have evidence of clinically significant portal hypertension, that is a liver stiffness 25 with a platelet less than 150, or just a liver stiffness of more than 25, then what you do, you start them on beta blockers, mostly carvedilol, to prevent decompensation. If they do not meet criteria, non-invasive criteria for CSPH, you just continue monitoring them with time, all right? So the goal in the old paradigm was to prevent variceal hemorrhage. The goal for the new paradigm is much loftier. We're preventing decompensation, mainly ascites and variceal hemorrhage. So what do we do now? You start the beta blocker, and this is what the guideline says. Non-selective beta blockers, preferably carvedilol, should be considered for patients with cackle, with CSPH, to prevent decompensation. They should not be administered in patients who have obviously contraindications and so forth. So that makes sense, right? Now, if the patient does not meet criteria for CSPH, the guidance says do not use beta blockers, and you should obviously treat the etiology and do lifestyle modification, no drinking, losing weight, and so forth, to prevent progression to CSPH. Now, what about patients who do not meet non-invasive criteria? Again, you want to do annual liver stiffness measurement, platelet count, that will tell you if they're evolving to cackle or not, all right? And this is particularly if the etiology continues to be uncontrolled. For example, if there's a patient that had hepatitis C and is now gone, you do not have to repeat these. If you have a patient with mast cells that the etiology continues to go on, then you have to repeat the liver stiffness and the platelet count on a yearly basis. Now, what about patients who cannot take beta blockers or who are intolerant to beta blockers? So you have to go back to the old paradigm, right? So you do an upper endoscopy, right? And then obviously, if they have varices that need treatment, big varices, you have to do ligation because they will not take the beta blockers. And this is what the guideline says. So you should do ligation in patients with calculum CSPH and high-risk varices that cannot receive beta blockers. And these patients, if they did not have adverse varices, they should be, screened like we used to do every year, blah, 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 and every 2 years if the etiology is controlled. But you can actually screen them also to see if they should have an endoscopy or not based on liver stiffness. So you would, if the patient has less than 20 or the platelet count is more than 50, they're unlikely to have varices. You can also just do liver stiffness and platelet count and decide who needs an endoscopy and who does not. Now, what about the patient who already has ascites? So the cow has left the barn, the patient is already decompensated. Now, in this case, you do want to know if they have large varices to prevent them from bleeding. And this is a study that included both, and I'm showing you about carvedil versus ligation. And this is a British study that included all patients, 51% had ascites, but you can see how carvedil was better than ligation in preventing not only variceal hemorrhage, but later on in a post hoc analysis, they also saw that carvedil was better than ligation, obviously in preventing further decompensation or decompensation and in preventing mortality. So even based on these studies, the guideline recommended that patients with decompensated cirrhosis not taking beta blockers who have never bled should undergo annual screening endoscopy. And if they have high risk varices, you can use either beta blockers or endoscopy, endoscopic ligation, but the preference is given to beta blockers, including carvedil, because they will have benefits that go beyond variceal hemorrhage, such as decompensation and death. Now, you will say, well, beta blockers, they can cause renal failure, blah, blah. So this is a study a very nice study that looks at patients with directly responsive ascites and refractory ascites and looked at the heart function and the renal perfusion pressure before and after propranolol. In the direct responsive ascites patients, there was no effect on blood pressure, but there was a significant decrease in renal perfusion pressure, but only one patient here actually decreased below the threshold that perfuses the kidneys. Problem was in refractory ascites. There was a significant decrease in blood pressure, and there was half of the patients actually dropped beyond that threshold that perfuses the kidneys, and actually 4 of them actually developed hepatorenal syndrome. So that ain't good. But what determined this drop in renal perfusion pressure was totally correlated with the decrease in blood pressure. So the recommendation is now that beta blockers, you still start the beta blockers in someone with ascites, refractory or not, but the dose should be dose reduced or discontinued in patients who develop persistently low systolic arterial pressure, less than 90, or any severe adverse effect. Now, if you have to discontinue the beta blockers entirely, you're back to the old paradigm. So you will have to do an endoscopy to see if the patient needs ligation to prevent variceal hemorrhage. Now, just another thing that we may have in the horizon to decrease portal pressure even further, besides beta blockers, is acting on resistance. 70% of this resistance is fibrous tissue, so it's structural. Unless we find an antifibrotic, we have nothing for that. But functional is, like I said, vasoconstriction. So statins increase nitric oxide bioavailability in the intrahepatic circulation and causes this vasodilation. And this is a very nice study, a proof of concept study by Juan Abrales and his group that looked at, there's a 29, 30 patients in each group, placebo and simvastatin. They looked at the HVPG, no changes with placebo. It decreased mildly but significantly in the simvastatin group with no changes in blood flow, and actually with an improvement in ICG clearance. This is a functional test. It means that the liver is better perfused, and this was much better. It increased with statins and without affecting mean arterial pressure. Look, we had been started using vasodilators for years in the hopes of reducing pressure, but the problem is that if you use a regular like nitrates, they will drop their blood pressure. So that was not good. Statins cause this vasodilation in the liver without causing a drop in blood pressure. So that's a good thing. And in a study that we did using the VA databases, we looked at, and they were very closely matched patients. So these were all patients with cirrhosis, and they were compensated, and you can see that the statin user was less likely to decompensate, and they're less likely to die than the patient that was not on statins. And look at here, when we looked at the specific complications, ascites was significantly lower in the statin user, and so was variceal hemorrhage. So there are at least 2 ongoing multi-center trials of statins, one at the VA and one from the NIH-CRN. And we're waiting desperately to look at the results of these trials to see. The problem is that with mast cell being the main etiology of cirrhosis, now getting a patient that's not on statins is a problem. So they have had major difficulties in recruiting. So, but for now, I mean, I would not give them a statin, but if a patient is on a statin, and we used to fear statins in a patient with cirrhosis or with liver disease, I would encourage patients that, oh, the cholesterol went up like 2, let's just give him a statin, all right? Anyhow, so what I've shown you now is that we have cirrhosis is a disease that is not a static disease. It advances through different stages. The median survival in the compensated group is 15 years. Median survival is 1.5 years once they decompensate. The compensated, they have no overt complications. The decompensated patient has overt complications that you can see with your eyes and your hands. Within the compensated group, you have patients without CSPH and patients with CSPH, right? These patients without CSPH, they don't have varices, they don't have collaterals. The patient with CSPH may have varices and collaterals, but varices have never bled. They're still totally compensated, right? The decompensated patient has ascites, variceal hemorrhage, encephalopathy, and we've now described a new stage of further decompensation where you have the complications of the complications, hepatorenal syndrome being the hallmark here. Those are very sick patients. Our goal is to identify these patients, the compensated patient that has CSPH, because we now know that we can prevent decompensation by lowering the portal pressure and by using beta blockers in these patients. And thank you so much for your attention. I invite you all to our Baveno conference in March of 2026. I'm now the chair of Baveno, like Paul just said. And this is where all the research in the area for the past 5 years get looked together. We plan on doing new recommendations. Thank you so much for your attention. Do I do questions now?
So it looks like the Baveno conference follows the Global Hepatitis Conference in LA. So you got time to fly to Italy.
That's awesome.
Our second named speaker today is Elliot Tapper, who is our Vinay Sundaram lecturer. Vinay, as you know, was a hepatologist, greatly loved young man at Cedars for many years who was building an academic career in acute on chronic liver disease and tragically died in a young age. And his family has gifted the Southern California Society of GI with an honorarium for a lecturer each year. And this year we've asked Dr. Tapper, who we all know from University of Michigan, to come and join us. Thank you, Val. I'm glad we got you out of Detroit or Ann Arbor. I'm surprised you were able to come to San Diego and make it out of there. But he's going to speak to us today on the quality of life in individuals with cirrhosis. So, Elliot.
Okay, it is a privilege to be here. So this is a lecture in honor of Dr. Vinay Sundaram. The last time this lecture was given, it was given by one of his mentors, and today it will be given by one of his mentees. Vinay loved hepatology. He loved his family. He was a lovable goofball, and he was my transplant hepatology fellow when I was a resident, and he was the first attending that I had when we were on the wards. And over years, we stayed in touch. We celebrated our wins and losses. He was always the first person to reach out to congratulate when something was going well and brag about the family that he loved. We would collaborate. We would talk about our research projects, accredited and uncredited. He was actually a site in a clinical trial that I'll talk about in slides to come. And the last thing that we ever discussed was putting together the follow-up study to our pickle juice trial, which unfortunately he wasn't able to do. I have no relevant conflicts of interest, but I begin with a message that I think many of us would find uncontroversial, and that is that our patients want us to help them feel better because their quality of life is often very poor. And of course, hepatic encephalopathy and ascites, these things trash quality of life. But if you look under the hood and do the kinds of studies that think about the independent drivers of quality of life, you'll learn from patients that it's not only the ascites, but accounting for the ascites, there's sleep dysfunction, their muscle cramps, itching, sexual dysfunction, cognitive dysfunction, and chronic pain, which are really the things that bother them, keep them up at night, and prevent them from thriving. Patients will, when you ask them in focus groups that we set up across the country, tell us that they want us to spend time not only addressing their edema and encephalopathy, but also their muscle cramps and their itching. And you might think that you are seeing dozens of people over the course of the day. You're trying to keep them alive and prevent decompensation, and you simply lack the time that is required to address these things because you're worried that the second you start talking about quality of life, you open a Pandora's box, and it's hard to wrap things up in a respectful way. And so rather than run away from that, I say it at the outset, and together what we have to do is build a playbook, one that can be deployed efficiently to identify quickly those patients who will benefit from first-line therapies before you refer to another specialist for help. The first thing that I'm going to address is sleep dysfunction, where in 1 second I can ask, during the past month, how would you rate your sleep quality overall? And if it's meh, I move on. But if it's really bad, I'll ask them to tell me on a scale of 1 to 5 just how bad it is to set that up in the chart, and then deploy my playbook. The basics here are that of sleep hygiene. Are you going to sleep in a quiet room? I recently learned from a patient that in order for his wife to fall asleep, she has to listen to the TV at max volume. This is not something that's going to be treated with a medication. Sometimes people are watching very stimulating things. So if you're watching Rambo, ask them to stop that. Have they tried reading for a little while? When was their last coffee? If those things aren't revealing, then we go to advanced or pharmacologic options. One of the medications that I don't throw around willy-nilly, but I'm more likely to use because having studied it, I know that it's not going to prompt falls in the middle of the night. And this trial shows that hydroxyzine dosed at 25 milligrams to start and then up to 50 milligrams induces a reliable improvement in quality of life while keeping these people sleeping like logs at night. So if the patient is telling you, well, I can fall asleep, but then I wake up at 2 a.m. and ruminate, hydroxyzine might be the medication for them. And in this trial, it was not associated with any worsening in cognitive function. But sometimes falling asleep is a problem. And sometimes you're worried about giving people anticholinergic medications. And perhaps for those people and those clinicians, melatonin is the intervention for you. Dosed at 1 to 5 milligrams, this is effectively an inert substance without meaningful side effects. And in the only randomized trial, it was shown to significantly improve sleep quality. The only problem is that it did so at the same rate as placebo. But I don't think this is a very big problem because there's a lot of evidence that placebo can be helpful for these connections between the mind and the body. There is evidence in randomized trials that open label placebo, giving patients a bottle that says placebo on it, so long as it is given to that patient in the context of empathy and caring, that open label placebo can improve symptoms of migraine, asthma, irritable bowel syndrome, leading us to the conclusion that sometimes slowing your clinic down for that 1 second to ask about the symptom and communicating your caring to that patient through the prescription of a medication that may very well be inert is enough for them. But if you believe that there is a connection between mind and body that can be leveraged for the improvement in our patient's symptoms, then let's go all the way. So Dr. Bajaj in Virginia, what he did is he sent patients and their loved ones to meditation class with a monk that would teach them compassion meditation. And lo and behold, what ended up happening is those patients and their caregivers also experienced improved sleep quality. Now, you might not have, like Dr. Bajaj, a monk on retainer, but you can tell somebody to download the Calm app. You can tell them to check out the Relaxation Response by John Kabat-Zinn from the library, or to watch guided meditation on YouTube. We all know that hepatic encephalopathy is associated with a reversal of the sleep-wake cycle. And there are many reasons why sleep can be bad, obstructive sleep apnea and so forth. But if you refer a patient with cirrhosis to another clinician about a problem, they're going to blame the liver. And that's what other people do when a patient has cirrhosis. So it does make sense to consider a time-limited trial of an HE-directed therapy to take off the table the possibility that their poor sleep is being caused by a liver-specific physiology. Dr. Sarah Montagnesi showed in a pre-post study that initiating lactulose was associated with improved sleep quality in people with defined cognitive dysfunction. And I took it a little bit further in a randomized trial where I simply took people with portal hypertension, ignoring their cognitive testing, just asked them, how bad is your quality of life? And if it was bad, I randomized them to lactulose or not. And at the end of 28 days, the people who were taking lactulose said that they were sleeping well. So within 28 to 56 days, you can figure out if this is a medication that is helping your patient's symptoms before moving on. Independently, the symptom which trashes quality of life the most and is prevalent in about 50% of patients, even child A patients, is muscle cramps. During the past month, how many painful spasms, cramps, Charlie horses, and synonyms to get at whatever they're calling it, have you had? And this, again, costs me less than a second. Then I ask the follow-up question, do they bother you? If they shrug their shoulders, I move on. If they do, I ask them to rate on a visual analog scale that I draw in the air between 0 and 10, just how bad those cramps are. If the number turns out to be 2 or 3, I move on. And if it's 5, I put that in the chart. And now I know a baseline to reassess or to have the nurse or other clinicians reassess after a trial of therapy. The basics here are to normalize electrolytes, right? People like to throw magnesium around at patients. And again, I'm okay with placebo, but there's no evidence that that actually does anything. If the mag is 1 and the K is 2, that's going to cause cramps, but you're not going to get anything else out of that. The other thing is that dehydration will actually cause cramps. And there's a lot of evidence around the way that the nerve muscle junction will fire more in people who are dehydrated. And Paolo Agnelli, he gave people albumin and this improved their muscle cramps. And I'm not saying to line people up for albumin, but maybe just make sure that they're staying hydrated. Maybe you could back off on the diuretics a little bit. And if those basics don't work, I deploy my advanced playbook. And here, I'll try to get at what the pattern of cramps are. So if they're having frequent staccato-like cramps where frequency is the problem, what that patient really needs is a stabilization of the nerve muscle junction. And the medications that have been most proven safe for this is likely taurine at 1 gram BID. Some people try baclofen, and there's small case series from the US that are trustworthy where that seemed to work. And I'll show you some data from non-cirrhotic patients where vitamin K2 was able to achieve a similar improvement. But some of these people have cramps that will last for several minutes, and they'll tell you, I get out of bed, I walk around, and I stretch. That's the only thing that helps. And here, the only intervention that has been proven, and I'll get into it, is a sip of pickle juice at cramp onset. The follow-up trial to that was to have people do a protocol of stretching or meditation before they went to bed, and neither one beat the other, but both of them were associated with reduced duration of muscle cramps. So the PICKLES trial enrolled 80 people at University of Michigan and Cedars-Sinai. Some of Vinay's own patients were in this trial. And we used some deceit. We didn't tell people what the arm that they weren't randomized to was, and we changed the name of the trial. And so 40 people got a pickle juice and 40 people got tap water. And what they would do is they would decant that into a glass or a water bottle. And when they woke up with a muscle cramp, they would take one sip. So there was like a glug, it hit the back of their throat. And then they would be able to rate by text messages that they got every morning about how many cramps they had, did the pickle juice or the tap water work, and how severe they were. And this is a trial that met its primary outcome. It reduced cramp severity, but because of its mechanism of action, it didn't improve frequency. They were still waking up, their sleep still was pretty rough, and their quality of life was poor. So the reason why we do this pickle juice is not because I'm asking them to chug a very salty solution. And if you want to get somebody hydrated, I gather if you drank a bunch of pickle juice, that's one way. But there's a ton of salt in pickle brine. What I'm telling people to do is have one sip that hits the back of their throat. There's 25, 20 milligrams of sodium in a very large sip. And there's a ton of basic science which has worked out the mechanism, where they actually took rats and electrocuted them and gave them pickle juice to prove where it's working. It's hitting a specific receptor in the oropharynx that communicates down the spinal column to abort the cramp loop. They electrocuted the calves of athletes and had them take a sip of pickle juice. And before the pickle juice even emptied from the stomach, they had a complete normalization of the cramp on an EMG. So it's the acid in the pickle brine, and that's why I would recommend dill or kosher pickle juice for patients. Here's the trial of taurine. They did a randomized crossover study. We're talking about like 30 people. The results don't knock your socks off, but like they were significant, and taurine was clearly doing something that placebo was not. There's this trial of vitamin K, which is supposed to improve muscle metabolism, that was significant and published a few weeks ago in JAMA Internal Medicine. I'm not sure, it's never been replicated in anybody outside of this, but like I said, these are relatively inert substances, and the patients are suffering and they want us to do something about it. I'll move on to itching, which can be particularly problemsome not as common as cramps, but when it happens, it's horrible. How much of the time have you been troubled by itching in the last 2 weeks? Again, if they shrug their shoulders, I move on. But if it seems bad, I draw my visual analog scale in the air, I document the number in the chart, and then I deploy my playbook. Even for Dr. Hirschfield's patients with rip-roaring PBC, the basics are still going to play for pruritus. How many times are you having a hot shower? Do you have dry skin? They might say no. And regardless of what the answer is, I'm like Googling heavy moisturizers with them to figure out which one they'd be comfortable trying, because dry skin is going to be driving most of the pruritus, and you'll chase your tail if you are throwing some of these other medications at people with cirrhosis. And we're already comfortable using hydroxyzine to help people go to sleep. And if they're staying up because they're itching, hydroxyzine is a pretty good Band-Aid to throw around. And now when I get to my advanced playbook, everything that I'm going to tell you about has been stolen from the literature for cholestatic hepatitis, cholestatic liver disease. And I'm going to tell you that I'm not sure how well any of these therapies translate to the people who have real deal itching, who happen to have MASH or hepatitis B. But we give them a shot. This is a picture from Dr. Ulrich Brewer's who gives us a good conceptual model of where itch is coming from. There are a variety of circulating pruritogens, some with names and some without factor X. And then that itch sensation it has a lot to do, again, with the mind-body connection, where some people with depression or anxiety are taking those nociceptive inputs and it's sort of metastasizing throughout their body. They're catastrophizing, and therefore there are randomized data that suggest that sertraline can be effective. Naltrexone probably also operates at the same level of neuromodulation. The first line therapy is to try to bind one of the known pruritogens, bile acids, and I'll start with cholestyramine. You can prescribe it at 4 grams, but then you won't know if you've gotten to the minimum effective dose. So normally I do it BID. I tell people it will bind other medications and to take it on an empty stomach. If they don't like the taste of orange tang, I try to prescribe cholestyramine at commensurate doses, but insurance rarely covers. If they have depression, I'll either treat that at the same time with sertraline or ask one of their other clinicians to join in. If they have alcohol use disorder and itching, naltrexone might be the medication for them. Rifampin is effective in this situation, although it tends to scare a lot of us because it's an antibiotic and it has lots of drug interactions. And then fibrates are effective for resolution of itch, and I don't use it in people with decompensated cirrhosis or borderline renal function, but it is definitely an effective option. It's uncomfortable, but it's important for us to recognize that our patients with cirrhosis terrify every single one of the doctors that they see. And the second that they think about liver, they don't think about anything else and they defer to you. Now, other clinicians will actually implement the plan that you recommend, so long as you say it's a good idea to do. But nobody is going to look at somebody with cirrhosis and ask, have you had any sexual activity in the past few weeks? How satisfied were you with your sexual function during the past few weeks? And we ask this question for a variety of reasons. 1, sex is part of the human condition and we want our patients to thrive. And 2, as you'll see, this is a condition, cirrhosis, with multiple endocrine disorders, and we might be able to affect not only these symptoms, but the general health of our patients. The basics here are actually the most important and the hardest to do, because I will sometimes ask about sexual function in people with active alcohol use, or I will just make sure that they know that alcohol trashes sexual function, that the rate of spontaneous recovery of sexual function with sobriety is very high at 3 and then of course 6 months. And so once you start to link these sorts of behaviors together so that people can understand just how much better these critical components of their daily lives can be, it's a really powerful way to link people to the motivation to take better care of themselves. Again, you might not be comfortable treating depression, but this is a cause of sexual dysfunction and you can identify it because you cared to ask and then say, please see your primary care doctor for bupropion or what have you, or a psychiatrist. We're trying to get these people on the transplant waiting list. Smoking is terrible for sexual function. And so I, as a hepatologist, am routinely prescribing nicotine replacement therapy. And so I'll list off some of the advanced options. You can talk about them in clinic. You can give them a dot phrase that you send to their portal, or you can get a handout from your urogynecology colleagues that you can share with them that recommends the use of lubricants. PDE5 inhibitors started at a low dose and up-titrated, and then considering the use of testosterone and vaginal estrogen. Vaginal estrogen is underutilized in postmenopausal women. It is associated with improved sexual health and function. And then I, as a hepatologist, am routinely seeing people in the post-discharge setting for recurrent hepatic encephalopathy due to urinary tract infections. And so this cycle of antibiotics off and on destroys the microbiome, not only of the gut, but everywhere in the body. And there are now nearly 30 years of randomized trials which show that when postmenopausal women apply vaginal estrogen, they can they basically repopulate the microbiome and experience a freedom from UTIs that is durable for several months. And so I can actually short circuit that revolving door of repeated hospitalizations that many of my patients with MASH cirrhosis have due to recurrent UTIs triggering hepatic encephalopathy with an intervention that has a variety of benefits. Many men have low testosterone, and low testosterone is associated with poor sexual function, but it's also associated with sarcopenia and frailty, things which complicate transplant decision-making and health-related quality of life. Dr. Marie Sinclair from Melbourne showed in a randomized trial that if you give people with low T replacement therapy, they'll have improvements in their muscle bulk and function. And in these trials, there's usually always, for some people, a significant improvement in their red cell count. So you can hit so many things that are important to you, like muscle mass, function, maybe anemia, and if you care, the sex life. However, there are some considerations here. I don't give this to people with active HCC, though there's no evidence that it causes it. You don't give it to people with active prostate cancer, though there's no evidence that it causes it. And you have to have a kind of informed consent discussion around the risk of stroke or heart attack because those signals were observed in other trials. Two final topics in the last 8 minutes or so. The first is hepatic encephalopathy, covert encephalopathy. It's associated with all of the worst things of cirrhosis. And I would argue that we don't have to wait until somebody shows up in the emergency department with asteriskis before initiating a therapy. We can look for cognitive dysfunction in the clinic, and it will cost us very little time. So you can download from iTunes Store the Encephalapse group from Dr. Bajaj. If you're going to do this to a patient, I recommend you do it to yourself first because it can be quite frustrating. But everybody is getting more used to the animal naming tests stolen from the dementia literature. You simply ask somebody to tell you all of the unique animals that they know in 1 minute. And if that number is less than 15, your patient is in trouble. But we're not interested in just treating a number on an app or a number of animals. We're interested in conditioning the decision to initiate a therapy that may very well increase the risk of diarrhea and abdominal bloating on something where the patient stands to gain from it. So I select patients who have the physiology that will set them up for HE, cirrhosis, portal hypertension, liver dysfunction. If I really want to be sure, I'll do a cognitive test and then I'll ask the question, have you been falling or are you worried about falling? What's the impact of cirrhosis on your daily activities? Do you have poor sleep quality? And now all of a sudden I have a question. I can initiate the therapy that the nurse can follow up on in 28 to 56 days and say, are you better? And then I can go back to the drawing board if they're not. So in a meta-analysis of all of the randomized trials that looked at therapies to improve health-related quality of life, the easier therapies like LOLA or rifaximin do not reliably improve health-related quality of life to the same degree that you get with lactulose. So even though these people are pooping 1 or 2 more times per day and experiencing bloating in the first couple of weeks, they will come back and tell you that their SIP, their Uroqual, their CLDQ is better. These are not just numbers on a page. They are questions about if they are participating in their social work, family activities. You are giving people back the lives that they want. But if you do that thing that so many do, where you just throw lactulose at somebody and say, take 30 cc's TID, titrate to 3 to 4 bowel movements, you're going to scare some people away because as long as this medication has been around, we don't really know how to personalize the dose. So here's my cookbook. First thing is, you tell them that it could be sickeningly sweet. So if they like that, take it from the spoon. Otherwise, mix it in ice water. It tastes like flat Sprite. Put it in your coffee. It tastes like sweetened coffee. Take 1 tablespoon, 10 grams of lactulose in the morning. It's not going to do anything. And then slowly ramp it up just to the point where it begins to soften their stool, maybe produce 1 extra bowel movement. And you can find the minimum effective dose for these patients. My final topic is chronic pain, which I think is the final frontier in health-related quality of life management, because we know that 70% of patients with cirrhosis have chronic pain and that the medications are terrible. The ibuprofen can cause GI bleeding, ascites, renal failure, and opioids can cause hepatic encephalopathy. We need to do better. The basics here are to make sure that they know and their PCPs know that Tylenol is okay. And I tell them the speed limit is 2,000 milligrams. They could probably go a little bit higher because they don't have as many cytochrome enzymes. But if you say 2,000 milligrams, you're in the clear. It's not going to work for everybody perfectly, but it will take a dent out of the pain. We criminally underutilize topical therapies that are effective and in randomized trials like topical diclofenac and topical capsaicin, which is incredibly effective for people with pain due to neuropathy. And there is no harm in asking somebody who has coverage to start exercising with a physical therapist. But a couple of advanced concepts here are to classify the pain type and suggest some non-pharmacologic options. So I'm okay with safe pharmacology, going after these topical NSAIDs, thinking about capsaicin or lidocaine for people with neuropathy, maybe even thinking about low doses of TCA or duloxetine. But I want you to start to think about how chronic pain is experienced by patients, that it usually starts as a bodily input and then it takes on a life of its own. It's very hard to blame the body for pain that affects so many different body regions. And most of the patients with cirrhosis and chronic pain have total body pain. This is a concept called nosoplastic pain. And the case in point for me was a study by my colleague, Dr. Nick Mizunder. He was interested in symptoms due to ascites. This is the classical example of bodily pain from cirrhosis. You get a distended abdomen, you have horrible pain. And so he had people rate their pain at the same time that he was measuring invasively the actual amount of fluid and pressure in their abdomen. And as the pressure goes up, the symptoms go up. But you'll notice that this line intercepts the y-axis, not at zero, but at a place where there is still residual symptoms. So people who are totally dry from the paracentesis, people where there's no pressure pushing on their abdominal wall or their organs, will still have pain. And what that is that's what happens when the bodily input, the nociceptive pain, becomes nosoplastic. It starts to take on a life of its own. And the only way to address that is by getting at that connection between mind and body. And so I use this slide here to say there are two key strategies that I would use before referring somebody for counseling or other self-management programs. The first is activation. So if you put somebody with nosoplastic pain, back pain in a walking program, if you tell them to buy a Fitbit or you look at their phone, you see that they're doing 900 steps a day and you say, well, why don't you try to do 2,500 or 3,000 steps a day? That in and of itself improves their perception of pain. So walking in and of itself can improve chronic pain. And the other is to think, hearkening back to prior slides about relaxation. Like I said, I did a randomized trial of stretching versus meditation for muscle cramps. Meditation was supposed to be the control arm and it failed me in that, but it improved their cramp, it improved their rating of the severity of the cramps. And so here we are, we have the opportunity to do something which certainly doesn't hurt them and can definitely help them. So in conclusion, I hope that you feel more empowered to ask your patients about the things that truly bother them. I hope I've given you some simple tools to track their symptoms and that you feel you can deploy these easy playbooks to improve their quality of life.
Thank you very much. Can you turn the lights up, please, in the room? That was a great talk, Elliot, and I would like for you to round on our residents and explain to them how to use lactulose, because they give enough lactulose to our patients that when you walk in the room, all the fluid in your body gets sucked out into the patient because their sodium is 150. Can we turn the lights on in the room, please? Thank you so much. And we're going to take questions. There, microphone.
This question for Dr. Elliott, Calvin Nguyen from
Can we
Kaiser
turn
Orange
the
County.
lights off there that are flashing in our face. Yeah, that would help.
So I'm glad someone is doing research in this kind of field of, the overall health of cirrhotic patients. So recently, one of my colleagues actually had a kind of a dilemma, and that brings up the question that I have here. So he has a patient, basically cirrhotic patient with some financial hardship and want to go back to work. And basically the question is, can we sign off on patient with mild or converted encephalopathy? He's running machinery. He's actually running a lab. He's a chemist. So that bring up the questions that if you have a patient that you suspect maybe there's some kind of mild encephalopathy, where are we with driving? Where are we with running machinery on these patients? We know that patients with encephalopathy can switch from a mild to a severe case in any minute. So are we gonna, I don't wanna use the word punish, but the moment that you put the diagnosis of encephalopathy in the chart, where are we signing off on these patients in this matter? And from a legal standpoint, if something goes wrong, where are we at?
That's a very good question. Now, what I was offering is a pragmatic approach whereby you initiate a therapy. You don't need to be very specific about the underlying reason for the cognitive dysfunction because we're just looking to help people feel better. But now you're raising the stakes and you're talking about medical legal risk and the specific question around the safety of employability, which is truthfully, beyond the scope of our control. Like any patient with cirrhosis can go on and develop work-related dysfunction. But from your own clinic, I think there's only a couple of things that you can do. One is this is a place where you can refer to neuropsychology for formal testing and put in the chart and have objective measures to say that their executive function is good or good enough, not just your own hunch or your animal naming test that you did on the spot. And then number two, you ask about the legality of this. And there are 4 states in this union, and I forget which ones they are, because I know it's not Michigan, where you have to report hepatic encephalopathy to the DMV. And so it's based on the same like mandatory reporting for epilepsy. So I would say most of us would say after an episode of hepatic encephalopathy that we don't want them driving and that we would document that as such. But after a few months, not everybody, like Dr. Garcia-Sao says, has a further decompensation with recurrent HE. About 1/3 to 4 out of 10 people with HE are one and done. It was that UTI that they had. And so saying that they can never drive again that's far too extreme. So I would say understand the legal context in which you work, and then that is a case for being as objective as possible.
Lupe, how do you deal with this at the VA? And push on your button. Yeah, thank you.
It's hard, we don't get those medical legal because many of these veterans are already retired that are not doing anything, but because it's a recurrent thing, right? What if they get constipated? Now they get encephalopathic and they're driving a car. It's difficult, I guess, but the patient and their families need to know that it's also that they should be they will figure it out earlier than anything else, that the patient is acting odd. And so so the wife or the daughter or whatever, you just tell them, this is what it is. And then they have to be alert to this, because the thing about encephalopathy is mostly a recurrent episodic type of thing. When it's chronic, then there's no question, then it's very easy. But if it's just a patient that gets constipated or gets more protein and then suddenly gets encephalopathy, that's something that you can control and that people can be aware of. And there are early signs that the family members or the work people could figure out.
Before we take the next question from Dr. Gish, I'm going to ask Dr. Lee and Dr. Nguyen and Dr. Shetty to come up, if you don't mind, to join us. So these are our local experts. Come on up, guys. And thank you. Okay, Dr. Gish, you are up.
Fantastic morning, thank you. Spleen stiffness and HepQuant. How do we use those today? They're available.
Spleen stiffness may be better than liver stiffness, especially for pre-hepatic for sure, or pre-sinusoidal, for example, PVC or things like that are mostly presented. The stiffness will probably be higher than the liver stiffness. The problem is we don't we're coming up with machines. It's much more hard to measure it because you cannot, unless they have big spleens. If they have a normal size spleen or not too big a spleen, it will be different. I tried it. I'm not good at procedures and anything that has to do with manual, so I can barely do a liver stiffness properly. But there are companies now that are doing it so much easier and that correlate. Our problem is that all our cutoffs that I showed you were done with a FibroScan. So they have a monopoly right now, but there are companies that are trying to show you that they correlate exactly well with the FibroScan liver stiffness and that they're easier to do, that you could actually do the imaging where you can see the spleen or the liver and it will make it easier. We need to find out the cutoffs for spleen stiffness. The Europeans are using it much more than we are. We are just doing liver stiffness for now.
So are they going to publish some data that we can use?
Hopefully, yes. No, there are some studies out there on spleen stiffness. They're not as many as you have. The evidence, the strength of the evidence is with liver stiffness.
Anybody here, you guys use any liver stiffness measurements with spleen stiffness? Anybody got that?
Yeah.
Elliot?
So we're not doing it routinely, but we have the spleen device in clinic.
We do too.
And so it's obvious when you were worried about non-cirrhotic portal hypertension that's like that. It's a slam dunk and it's beautiful for that. But it's also simultaneously like a validation of the liver, like, because we know that like the positive predictive value of a high liver stiffness isn't perfect. And if you get two commensurate measures that look rough, then that is somebody who I'm much more confident has cirrhosis. So who are we doing it in? It's about 10% of our FibroScan population is getting spleen stiffness.
HepQuant was the second question. Who's using HepQuant? It's an LDT. There's many sites around the US.
No, I have an issue with HepQuant actually. It's measuring shunting in a way, but does not correlate well with any of CSPH or anything like that. So I have an issue. I have had an issue with HepQuant for a while, that it measures shunting, but doesn't really, there's not enough data to say this is CSPH or not CSPH, or what is this shunting about.
Mm-hmm.
Thank you.
Question.
Oh, we cannot hear. Oh, it's a good question. The answer is
Can you please repeat the question, please? Okay.
He's asking about EUS guided portal pressure measurements.
Okay.
And so this is A, it's not validated. B, is super invasive. I mean, so the whole objective of the CSPH is that it's a non-invasive test. If I were to do something invasive, I'd rather do an HVPG, then try a thing where you have to anesthetize the patient, right? Put him face down, where it may alter the pressure measurement. It says I consulted for the company, so it isn't like they're alien to my opinion. But the main problem is the internal zero. You need a zero for any blood pressure. You have a high pressure in the blood. The pressure is always reflecting a gradient. When you measure the blood pressure, you have the systolic and the diastolic. HVPG, you need a wedge and a free. When you're doing a portal pressure measurement, you're sticking the needle in the portal vein and getting a measure. What does that even mean? What is your internal zero? So they have another device that now in some other way measures a free pressure. So they do the gradient. But unless you can validate it with all these measurements are done by doing the HVPG, unless they can say, okay, this measurement validates and it's exactly the same, they correlate exactly, that's fine. But why would you put someone, well, you can do liver stiffness. Why would you put someone in anesthesia, put them, it doesn't make, where it makes sense? In this spleen stiffness is going to be much better. It's going to make sense in the types of cirrhosis that are mostly pre-sinusoidal, pre-hepatic, or you see, because then you're measuring the portal pressure directly. But then maybe spleen stiffness is going to be a better non-invasive test. This is an invasive test.
Great, thank you.
I want to ask everybody on the panel, except Lupe. I know Lupe's answer already, but last year, the guidelines for portal hypertension changed significantly. And what should have happened is in the last year, we should have done a lot less endoscopy than we did in prior years. So starting at that end of the table, I want to hear the answers from you guys. Honestly, has that happened?
No, so far it hasn't in our practice. I feel like we're still doing a decent amount of endoscopy.
You're still doing a lot of endoscopy.
Yeah, but hopefully in the coming years it changes, but not yet.
So is that because the patients are already scheduled or somebody else is referring them, or you're just still doing it?
That's a good question. So I think in majority of the group, most of the patients that we tend to see are decompensated patients, are probably on the sicker side. It's usually a follow-up for a recent hospital bleed. Screening endoscopies, I would say, may have decreased just by a little, but not enough.
And there's a conflict, right?
Yes, there is. That's what I'm trying to get at.
I'll say that I've significantly reduced endoscopy and referrals for, screening and then also follow-up. So using carvedilol has really changed my practice.
Elliot?
Yeah, so it is practice variation where there's some people that will not do anything and they're intentionally ignoring the guidelines. But in general, my group of 19 hepatologists, I would say it's about 15. We have stopped routinely doing screening endoscopy, and it's freed up space for better reimbursed procedures anyways.
I would agree. I think at UC Irvine, we have decreased the amount of screening endoscopies. Oftentimes the endoscopies are paired with colonoscopies. The endoscopies are done for other things like GERD. So, and in a patient with compensated or decompensated cirrhosis. So we're not doing them for the express purpose of first-time variceal screening.
Well, I'm happy to hear that.
How about at USC, Jeff? You guys doing less endoscopy?
Right, yeah, much less.
Yeah? Yeah, okay. You said you are. All right. Good. Charles.
Question for Dr. Tepper, and that is, a lot of our patients already self-medicate with cannabinoids in management of just life. And your suggestion that narcotics certainly have a place in managing chronic pain. Do you have any input on cannabinoids one way or the other, or certain types of cannabinoids to possibly advise?
Yeah, so like my patients teach me so much about what they're growing, and they tell me about the mixture of CBD and THC, and I'm surprised everybody is using it. And so it's advertised to treat everything. And so is it a placebo? Is it actually helping? Are they becoming dependent on it? Is it making things worse? I have no way of knowing. Like, is the NIH going to fund a trial of gummies for patients with cirrhosis? I'm not sure. So I'm not telling people to stop unless you can identify that there's a significant problem, but it's this problem where everybody is taking it. The opioids thing that you're talking about, like I think opioids are much safer, lower dose, making sure that constipation is against the law, and that you ensure that they have a proper bowel regimen. But I don't prescribe either of these things.
How about you at Yale? You guys getting stoned at Yale? Come on.
Well, everybody is getting stoned everywhere, I think. Yeah.
This is California. We
should just get on the bus or
So the only population where I actually really delve into this is a patient who is headed towards transplant. And at that point, I will talk to the transplant center. What is their protocol? Is this a substance that will actually preclude them from it? Do they need to start going into substance abuse? Are they going to be tested? Is a positive test going to dissuade them? Do they need to enroll in? If the answer from the transplant center is otherwise no, and it's managing their pain, then I will allow them to keep going on it. And I will tell them that this is something that needs to be discussed with at the transplant center.
And then a question for Dr. Tsao, and that is at 2 a.m. I'm doing this upper GI bleeder, and of course I encounter large varices and sentinel signs. I've obviously got to treat that, but am I going to add carvedilol afterwards?
So yeah, so now we're talking about prevention of recurrent bleeding. So if the patient comes in bleeding, you do what due diligence, do the ligation, do the pressing, vasopressing, whatever you have. So you have to just control the bleed. Once that's controlled, then they have to be started for sure on something to prevent rebleeding. And most of the trials are done with propanol. I would claim that even though there's no trials on this, Carvedil may be better than propanol in preventing rebleeding, but I have no data to support this.
So do you start them in the hospital when
Yeah.
they,
Oh, yeah, before the patient leaves.
before they leave?
Mhm.
Sam?
So 40 to 45% of patients in the US are on a beta blocker and a statin for hypertension and dyslipidemia, so that they are presumably prevented from getting portal hypertension and HCC.
And HCC, I'm not sure, but portal hypertension, yes, if they're well beta blocked and on a statin in a patient with cirrhosis. Now, it's very odd that a patient with cirrhosis actually has hypertension. You know, they're usually, the more decompensated they get hypotensive. But if they're on these drugs for cardiovascular, they're fine.
I had a question for Dr. Tapper. What do you do about caregiver fatigue?
What?
Caregiver fatigue is the number one thing that they want is for their patients to, for their loved ones to do better, and the better support that we can have. Sometimes that involves respite, where we park them in the hospital, where the more we tell them that their feelings matter, that they can take a break from them to go out with a friend for lunch, that kind of thing matters. I tried to do a randomized trial of positive psychology, where people would do certain exercises. It didn't help. It may have made things worse. What they really want is a break. What they really want is financial support to take care of their loved ones. I don't have any positive messages beyond that, except the experiences that if you look at them and say you deserve your own time, that you shouldn't feel guilty leaving them for a few hours at a time, and you set them free from that risk of guilt, they will do better in the long run.
Can I expand the answer to the previous question on prevention of rebleeding? These patients have to be on beta blockers and ligation, right? So you have to eradicate the varices. And the other thing that I think we're perhaps delaying too much is thinking about tips placement. And this is another lecture that I have that I think we wait for. Once the patient bleeds again, they should go for tips. For ascites, we're waiting way too long to put in tips. And now that we have controlled expanded stents, I feel a little bit more comfortable prescribing tips earlier rather than later. So don't wait for that second bleed. Once they have a second bleed, they go for tips. Once the ascites becomes like refractory, like early on, not until they're getting a weekly paracentesis, you think of doing a tips. Now you can do a smaller stent, less encephalopathy, and then expand it as they go along.
Question.
It's just piggyback on what you just said, Dr. Garcia. So at ASLD, there's some European hepatologists, they do their own tips in the hospital. They do their own tips in the
They
hospital,
all do.
especially some Spanish ones. Do you think that's a direction for hepatologists in the US
No,
doing tips?
So
never.
Explain that, Lupe, about using their own tips. Explain that.
No, it's not their own tips. They place the tips.
Yeah,
Tips is made by Gore is the normal tip stents, but the hepatologists do the HVPG. That is what is much trusted. When it is your patient and you're vested in your patient, you're going to do much better than a radiologist doing this. So they do all their HVPGs. They do all their tips placement in Spain and in many places in Europe. Some of them do the radiology and then they do the follow-up stents, but in Barcelona for sure they do their own tips. And so that's why the preemptive tips, the one that when the acute variceal hemorrhage patient that meets certain criteria of severity, they do preemptive tips. So they do the tips right before the patient is going to fail, right? But in the US, this is never going to happen. We have all these, they have to meet all the boarding and everything. We're never going to be qualified to do the tips.
Agree with you. Can I ask a
Throw-
question to follow up on Bob's question, actually, about NITs again, FibroScan? So, there's a lot of data in terms of using FibroScan for diagnostic and prognostic purposes. Far less data on using it for longitudinal monitoring. But, obviously everyone is repeating FibroScan. So what is your practice and how often are you doing it and what are you looking for? And then second is, what about, ELF score and, MRI? Are you using this?
That's a great question. Okay, so you try to do non-invasive tests as much as you can. Right now, we do FibroScans. Any patient that has chronic liver disease, we do a FibroScan, see where they are. Do they have cirrhosis? Yes or no? I mean, there's always gray zone patients that you may want to repeat, or the very obese patient in obesity. And I didn't have time to show this, but in the obese NASH, you may have higher stiffness values. It overestimates liver stiffness. So it's a problem in the obese patient. You have to do a correction. There's a nomogram where you could correct by BMI. But obesity, when you see a very obese patient, they may have like CSPH numbers and they really do not have CSPH. So that is a whole thing. But so we do it with any chronic liver disease. If the patient does not have CSPH, then we keep repeating it on a yearly basis until they get CSPH. That's it. And they're fine. Compensated. We're talking about the compensated patient. If right away at the first FibroScan they have CSPH, we just start on the beta blocker and don't repeat it. Because it will not correlate with a decrease in pressure, right? It just tells you how stiff that liver is and how high the pressure is. So once they're starting a beta blocker, that's it. You don't do any more FibroScans. All right. In the decompensated patient, there's no reason to do this. Right? If the patient already has ascites, there is no reason to do a FibroScan. You have a diagnosis.
So once they're starting on carvedilol, you stop.
Yeah. Yes, because there's no sense. You already
You've already made a decision. What about probably the biggest barrier to carvedilol in our center is that most of the patients now with portal hypertension have NASH. They're all on antihypertensive drugs when they show up to see you. So it's not that easy. You don't just start them on carvedilol. You got to contact their cardiologist, their primary care doctor, get them to agree to stop their antihypertensive, start them on the beta block, start them on carvedilol. You got to do all this.
But in a way, at the VA, for example, if the patient has MASH and it's already on carvedilol or already on propanol for blood pressure, they may not even need a FibroScan, right? Because all you do is call the primary doctor, call the cardiologist, tell them, switch them to carvedilol, and that's it.
Exactly.
One final question. What do you think about the interim pump that we're actually taking or is going to be used for ascites into the bladder? Dr. Long's,
terrible.
You think it's
Repeat the
terrible?
question,
That's
please.
The pump, the alpha pump for ascites. I just feel that
to avoid PSC.
anything that is not pathophysiological to me, it makes me, so this is, it's just diverting ascites into the bladder. Okay. They get infected, they get hypotensive because it's not working on the pathophysiology, you're just draining the fluid. It's going to relieve the patient. Yeah. So internal cases where but again, and I'm in a proponent that once the ascites starts and you have like a second or a third tap, do a TIPS. This is my thing, right? Even the Levine shunt in a way made more sense because you were diverting ascites into the systemic circulation, but to just drain it into the bladder or to drain it outside, you're going to get infection, you're going to get hypotension, you're going to get kidney dysfunction.
Heather.
I was just going to follow up on Lupe's comments about the converting the beta blockers as one of the most useful tools that I have in clinic is the dose conversion table that was developed and disseminated within the VA so that I can either make the switch myself or communicate with the primary care or cardiology and say, can we move from this metoprolol to this specific dose, really to help facilitate that change.
So you don't just put them on 12.5. You pick up.
We'll look to see, what's the equivalent dose. Particularly if it's being used for heart failure or hypertension, we have to be mindful of we're treating to that target, not just the portal pressure.
Exactly.
Yes, one comment, one question. Switching beta blocker is tricky. It's very important to talk to the cardiologist because I learned not all beta blocker are equivalent and somebody has AFib. Some of them are more prone for rate control than others. So that's word of caution to do self change on yourself. Second question is for carvedilol. Not many patients could go up to 12.5 milligram a day. So what's the acceptable dose practically for these patients? And if we can get to 12.5, are you advocating continuing surveillance endoscopy for these patients?
The question is if they can't take 12.5.
Right. So the first comment I agreed entirely with. I forgot what it was that I agreed with it. The second one is, we don't do it ourselves. We ask whoever prescribed the beta blocker to see if they can make the conversion, right? So we're not doing it ourselves unless we prescribe it to begin with, which we never describe. All right. Anyhow, so in a patient who, what I forgot.
You can reach 12.5 milligram of carvedilol.
So you go up on the dose. If you get to the maximum dose, that's tolerable. All right. So if it's 3.125, that's where you stay. Now with MASH cirrhosis, we're finding that they tolerate it much better. They already have hypertension. So in the patients with alcohol or Hep C, we had much more intolerance to beta blockers. Now with MASH cirrhosis, they tolerate it much better.
So if you hit the 3.125 BID max dose that they could tolerate, do you still need to do endoscopy or?
No. The endoscopy is only if they do not tolerate any beta blocker.
No.
If they don't, then now they're left without any. Now your goal is to prevent variceal hemorrhage.
Right.
So then you now do a screening endoscopy. But if they did tolerate, and you had it, meaning that you tolerate means that they had an effect from the beta blocker, no matter how low the dose was. Sometimes we have them on the minimum dose, and they still have, the bradycardia. I mean, the lowering in the heart rate and maybe a little bit of the blood pressure. We know that it's working. We just leave them on the minimal dose that's tolerated. If no dose is tolerated, then you go to the endoscopy.
So, except he's at Cedars. You get an endoscopy at Cedars if you skin your knee.
Actually, we're changing. That's Scripps now.
That's a Scripps you get. If you park your car at Scripps, you get an endoscopy. Come on. Last question.
Going off of that, if you're on 12.5 milligrams of Coreg per day and your heart rate is still in, the 90s or 100s, are you going up to 25 BID? Are you still, if you're at 25 BID and still having high heart rate, are you going to want to do an endoscopy and just get them off of that because it's not helping?
So if they never even drop their heart rate at all, I have had actually those
who are like that.
That doesn't have any. You don't know if they're beta. I would talk to the cardiologist and see what is going on.
I'd get an EP study. Yeah, it's like they're on such a
no, exactly. So I've had like a couple of patients perhaps where this doesn't happen, and you keep rising the dose and there's no effect. I would send them to cardiologist and see what's going on.
So you're still doing endoscopy for screening because it's lowering.
Yeah, that I don't know what the answer to that is actually, because if there's no effect of the beta blocker, then I would go down to the endoscopy, right?
Okay, so kind of going off of that, if you have someone that's on 12.5 milligrams per day,
Yep.
And their heart rate is elevated, are you still going up to the
go
dose
up.
of 25 BID to?
You go to the maximum dose is recommended.
Yeah.
And then you stop.
Okay, perfect. Thank you.
We're going to take a break till 11 o'clock. Please come back at 11. Thank you, panel members.
Welcome back for the last session of the day and the meeting, actually. Dr. Pacro said I need to do some work because he seems that only Jeff and Paul have been doing all the work and I've just been relaxing. So I have the pleasure of hosting this last session, and our first speaker will be calling back Dr. Hirschfield, who, as you know, is the Lilly and Terry Horner Chair in Autoimmune Liver Disease Research at Toronto General, and also the director of the Francis Family Liver Clinic. He gave us a wonderful talk yesterday on cholestatic liver disease. And so today we'll ask Dr. Hirschfield if he can update us on the new abstracts from AASLD.
Great. So select crowd as the others are getting their coffee. I think, what I'm going to try and do is just sort of go through some of the ASLD abstracts, but it's hard to follow on from what we just heard from Lupe and Elliot, just the importance of just simple things in managing cirrhosis and quality of life. But I'm going to try and focus you back now towards cholestasis. I obviously got some help for these slides. Aparna Girl from Stanford did an amazing ASLD cholestasis debrief, and that definitely helped me in putting together some of the content. I think one of the things I want to start off with is that there is much more choice in PBC treatments. This choice is slightly controversial at times in terms of the difference between what we're doing in the real world and what's happening with licensed therapies and what's happening with off-label therapies, and also how that then marries with also regulatory issues around how drugs get approved and then stay on the market. This is a big study led by Ronke et al. With over 1,700 patients, where they've got patients on OCA and patients on fibrates, the majority of them whom were bezafibrate, because this is across the world, okay, and some patients on what we would call triple therapy, because all these patients are usually on UDCA. And then what they've done really is just try and track what's happening to the patients, so what's happening as they come to your clinic, essentially, okay, and see where they land. Okay, and the reason this is interesting is because it's giving you some real world themes and feel to what's actually happening, not just sort of the more traditional kind of papers that you might read. And then they've got a reasonable number of patients at follow-up, and further work is going to come from this group, which is sort of under the Global PBC Consortium, where they'll be looking at biochemistry. But I think there were a few key highlights. Treatment follow-up, 96 OCA patients added a fibrate, 22 fibrate patients added OCA. Now remember, there's a little bit of bias because OCA has a threshold for reimbursement that fibrates don't. Okay, discontinuation rates for OCA was at around 33%. Pruritus was relevant, and 128 switched to fibrates. But the discontinuation rates for fibrates is not zero. The discontinuation rates for fibrates in the real world, where your patient comes back and says, I might have myalgias, or you're looking at their creatinine, was 21%. Okay, so I do think this is sort of highlights that we have opportunities with second-line therapies. How we actually use those second-line therapies in practice actually is informed by what we see in the clinic. And we know that OCA has issues with pruritus, and we know that we're going to be choosing our fibrates, our PPARs carefully, thinking about, transaminase activity, thinking about renal function, thinking about myalgias in the real world setting. And then the details here are less important than the concept, because this is now also area of controversy around how do you prove a new drug that we develop for PBC actually changes outcomes. And this is a very important Italian study that no doubt will also be published soon, where they've actually got many hundreds of patients on obeticholic acid, okay? And they've been able to look at their cohort, which is real world, okay? It's called the recapitulate cohort. It's over 400 patients who've received OCA in Italy across a network. And they've compared it with registry patients, global PBC. Again, this is not perfect. It's actually very difficult to do this in a perfect way. But in this study, and it actually mirrors other data from other approaches, there was benefit of second-line therapy. In this case, the second-line therapy was obeticholic acid. So again, as a community, what we're going to have to do is continue to learn how to evaluate the impact of new treatments, be that OCA, be that elafibranor, be that seladelpar, be that bezafibrate, etc. And it's very hard to do, and it's not easy to do it to the highest level of stringency. But from a patient perspective, they're looking for guidance from you as their clinician. This is US data, Reddy et al., abstract 4313. Target PBC was a cohort of PBC patients receiving usual care, and some of you may have been involved, over 5 years across multiple sites in the US. And what it's looking at is this concept that we're getting better and better at our biochemical thresholds and what we think is good treatment for our patients. And I talked about it yesterday, intuition. Intuition in PBC is normal, fast normal bilirubin, and the third normal is normal symptoms. Okay, so in the target study, they've been looking at deep response, alk phos normalization, bilirubin less than 0.6, and looking at outcome. And they've got, a group of patients where they're able to identify those deep responders, okay, so-called PBC remission, if you want to talk about it, okay? And what they are showing is that the patients with the best test, this is replicating data that we had from global PBC, including patients in particular with advanced fibrosis, are the ones who do the best. Okay, so it reaffirms this concept that we're in the right territory, that when we're choosing our therapies for PBC, when we're setting our goals with our patients, we are looking for so-called deep remission in treatment. Okay, and in fact, not surprisingly, really, because the more fibrosis you have, the closer you are to an event, the impact of a deep response is more pronounced in patients with advanced fibrosis. Okay, that means that across our patients, we have this journey with PBC, the newly diagnosed patients, and then the so-called legacy patients. Our patients live a long time. And so, it's always important to be looking at their biochemical response in the patient who comes to clinic. In fact, we just published that in JHEP reports, where any time measurement of biochemical response is prognostic. So it's not just the initial flow from diagnosis, it's all the legacy patients as well. Okay, this then dovetails into two abstracts, one on seladelpar, one on elafibranor, okay, where of course with these big phase 3 clinical trials, big by PBC standards, we'll now see the authors come back and look in subgroups. And a very important subgroup is patients with compensated cirrhosis. So the PPARs are not used from Charles Pugh B and C, at least not in the US. I think the label may differ across the world, but in the US setting, you're not recommended to use it. But you will encounter patients with cirrhosis. I just showed you that deep response is important in patients with PBC and advanced fibrosis. This was Villami et al. Abstract 146, looking at the experience of patients with cirrhosis on alkaline phosphatase changes, having received seladelpar, PPAR delta agonist. Okay, and the message is that there is biochemical efficacy in cirrhotic patients receiving seladelpar. This was not a total surprise. There's similar data from OCA and no doubt similar data from elafibranor. Okay, but the other important thing was that there was no difference in adverse events. So this should reassure you as you're making your choice with this, this spectrum of different drugs that you now have, that he has data from the seladelpar clinical trial that there's evidence of cholestatic and liver injury improvements in patients with cirrhosis, same as without cirrhosis, and that there wasn't a difference in the adverse events profile. This was then Chris Cowdley presenting from ELATIVE, long-term efficacy and safety of elafibranor and PBC, interim results from the open label extension of the ELATIVE trial up to 3 years. So all of these clinical trial agents then have an open label extension, and we try and learn from that ongoing use. It's difficult for all of these agents because you lose placebo. Okay, it's a reality. Okay, after the patients transition onto open label drug, but it's important for you to understand and to see. So in this study, Dr. Cowdley showing you that there's ongoing biochemical efficacy of elafibranor, particularly as patients switch from placebo onto treatment. Now, let's switch gears and just talk a little bit about PSC, because PSC is this black box and we're really struggling to go forward. And we're trying to get better tools to design our clinical trials better. I like this abstract from Michael Trauner because he's used a very big clinical trial that many of you may have been involved in, the Silafexor study from Gilead, which was a synthetic FXR agonist, which had a negative primary outcome. It didn't meet its efficacy. Complicated reasons why. Okay, but what he's done is now with the sponsor, obviously, is looked at the ANALYS score, which is this MRI score, and looked to see how that correlates with other biomarkers and outcome. And the ANALYS score has got sort of 3 components to it: portal hypertension, liver dysmorphy, and the intrahepatic bile ducts. And it's interesting in PSC that the MRI scores have not really taken off in terms of our use in clinical practice or in clinical trials, but maybe they can be used to help us predict who's going to be better patients to include in a clinical trial. Because what you can see is associations between the analysis score and ELF, associations with liver stiffness, and associations with cholangitis and possibly clinical events. Okay, why is that important? It's because for us to get a successful phase 3 clinical trial, particularly if we're going to expand it to, say, clinical endpoints, including perhaps cholangitis, if we can pre-screen our patients and try and, really narrow down their inclusion-exclusion criteria, maybe something we could do is take the analysis score and say, if you have an analysis score greater than 2, that predicts you're more likely to get cholangitis. And that's a way to enrich our study for patients who are likely to have a clinical outcome in the study. And therefore, if a drug is beneficial, we can actually measure it. Because what we've learned in PSC is that all-comer studies do not work. When you put everybody into the clinical trial, you have this big heterogeneity, you can't measure your endpoints. So that's why I thought this study was interesting and will perhaps inform better trial design. This is work from Lung et al. It's actually work from our program. You've heard a lot about liver stiffness in this meeting. You heard a little bit yesterday. You heard some really insightful comments this morning around cirrhosis. This is a study that we've done in Toronto, which we're now trying to validate with US data, maybe even data from Alberta. 400 patients, 84 composite events with PSC, over 1,300 valid liver stiffness measurements. Okay, it wasn't supposed to be rocket science, but it's to demonstrate the association between liver stiffness and outcome. 4.4-fold increase in risk of decompensation, transplant, or death per 1 log increase in liver stiffness. Okay, and to validate thresholds, 9.6, 9.6 to 14.4, and 14.4 were the thresholds. This comes from some prospective data from France and Europe, which is going to be published soon. But essentially, again, why are we doing this? It's not just for clinical practice. I do use fibroscanning for PSC. I know it's variable, but I tell my patients that once their fibroscan is above 10, they're entering into a different trajectory over the next 10 years. It helps them plan their lives, okay? But again, this might help me recruit to clinical trials and enrich the population with patients likely to have events so that I can actually have a clinical trial, I hope in the future, that's actually positive and not negative, which is so desperately needed in PSC. So that then flows into an abstract from Professor Cowdley in Seattle of bexotegrast. Okay, so there has been a lot of effort at phase 2 clinical trials in PSC. Okay, and I'm going to show you some of the data that's at ASLD. Some of this data has been previously presented at EASL. Okay, bexotegrast, I mentioned yesterday, is an oral inhibitor of alpha V beta 6 and alpha V beta 1 integrins. So what essentially that does is, it's a non-systemic TGF-beta inhibitor in essence. It does other things in this integrin pathway. Systemic TGF-beta inhibition has not been successful and has been associated with side effects. Biliary epithelium and other fibrotic liver conditions, the integrins are very important in liver fibrosis, and it's also very relevant in pulmonary fibrosis. This was a clinical study which is short and early, focused always on safety, focused on dose, okay, with some exploratory endpoints. This is what we have to do in PSC clinical trials. We have to work really hard at the beginning to try and find the right sort of drug and the right dose and the right population to then plow into phase 3, we hope. This is the baseline data from Professor Cowdley's study. It's sponsored by Pliant from San Francisco. It's where they're based. Okay, these patients have elevated ELF scores. Okay, they have elevated liver enzymes. Importantly, as the primary endpoint, there were no safety concerns between the highest dose, bexotegrast 320, and placebo. Okay, and there's no difference. There was a signal, again, of quality of life, pruritus, cholangitis. This is just a signal, but again, it's the kind of things we're looking for as we think about how to then develop the future study of an agent. Okay, if you then look at the comparison between bexotegrast and placebo, and you're looking at ELF-FOS, really probably no significant changes. The sum of the signals for cholangitis and pruritus, there's a difference. Okay, so that's of interest to patients. And even with the itch NRS, it looks like the placebo patients had a trend to being more itchy than the treated patients. Okay. We don't have very good biomarkers for PSC clinical trials. We really struggle. ELF-FOS is a very good prognostic biomarker in PSC. It's not a very good biomarker in short-term studies for change, okay, because it fluctuates too much. Now, yes, in theory, if I had the perfect world and I did a clinical trial of a drug that works for PSC, if ALT-PHOS wasn't ultimately different between treatment and placebo, that would make no sense over many, many years. But in a short study, it's not good. So we're using things like ELF, PRO-C3, transient elastography, and we're trying to learn. And we're also trying to use better MR technology. So this is shows evidence, some data in a subpopulation in this clinical trial of a contrast MRI, looking at enhancement and time of arrival of the contrast agents to the bile duct. What this data shows at a very early level is that the drug was well tolerated and there were some signals of efficacy. Okay, so this then positions you to see, could you take this into phase 3? And that's obviously up to the sponsor to decide how best to do that in collaboration with the FDA. Okay. The other late breaker, Professor Bolus from UC Davis, okay, CM101. So this is actually really interesting because this was a humanized monoclonal antibody targeting CCL24, okay? And this is in an axis that promotes inflammation and fibrosis. And it's relevant not just to PSC, but scleroderma and other sort of fibrosing conditions. And this is early data again, okay? But it's intriguing data. It's IV, it's different doses, it's got a 15-week treatment period, it's got a very big emphasis on safety, okay? And then it's got some open label data, but it's also more importantly, trying to get exploratory signs that this drug could be anti-fibrotic as well as anti-inflammatory, okay? Clearly what our patients need with PSC, okay? And what you can see was, number one, there were no safety signals. Okay, so that's very early. It's a small study. But again, they are looking at liver stiffness and they are looking at changes in, biochemistry and liver stiffness and looking for signals. And there were signals of a difference between placebo and drug. This doesn't mean that this drug is, definitely working. But in PSC drug development terms, it means that you've crossed the line, that you've made progress, and it looks like, more specific inhibition of an important sort of chemokine pathway may be anti-inflammatory, anti-fibrotic, and anti-cholestatic in PSC. Okay, again, trying to work out which is the best population is difficult, and it seemed that there was a bigger effect in the moderately advanced fibrotic patients, which is a challenge for us to recruit to if you think about clinical trial design for PSC, but encouraging nevertheless that there were a number of late breakers at ASLD for PSC, that we're not giving up easily. Okay, I now show you something which sort of dovetails on from Dr. Tapper's talk, the importance of symptoms in chronic liver disease, cirrhotic liver disease, and in particular in cholestatic liver disease. This is baseline data. It's a poster from the global linerixibat itch study of efficacy and safety in PBC. So I want to remind you that linerixibat is an IBAT inhibitor. The clinical trial is focusing just on itch. Okay, so here you have, why there's excitement in PBC, that people are prepared to do large clinical trials, 238 participants, that's actually larger than some of the treatment studies, okay, of a symptom that's very impactful. And doing symptom clinical trials is very difficult, okay? It's very hard to do symptom clinical trials, but it's very impactful for patients, okay? We hear what our patients tell us, but trying to quantify symptoms into something that you can measure is not easy. The two key speaking points to this poster were really that, this demonstrates that not everyone who's symptomatic has a high ALT-PHOS. Okay, there's no reason to have a high ALT-PHOS and not to have itch. And it also demonstrates that this was a real world effort to treat itch, because 22% of the patients were on fibrates, okay, already. So clearly, although PPARs do have a role in itch management globally, 1 in 5 of these patients were already on fibrates and still had a symptom burden that they rated to be challenging. And then you can see there's the whole array, so actually mirrors Dr. Tapper's slide, of all the different things we try, all the goodies that we have a go at, okay, in different measure to try and treat a symptom. There was a press release on the last day of ASLD, and the press release simply says that the clinical trial met its primary endpoint, okay, which means that, the sponsor announced that treatment was better than placebo, which in itself is a major achievement for a symptom study, let alone, a treatment study. So exciting times for PBC. This then follows on. This is from Andreas Kramer presenting some of the data from the response study going back to seladelpar. Okay, you'll remember that that in the seladelpar clinical trial, a key secondary endpoint was the improvement in pruritus. Okay, this is just further depth into that, looking at patients with pruritus over the clinical trial and looking at how patients have shifted over time based on their baseline itch score. Okay, so itch scores are complicated. These are quantitative. This is like 0 to 10 essentially, but again is just re-emphasizing the improvements in itch, sleep disturbance, and fatigue. But remember, this is a population of patients with active disease. They are recruited not because they're itchy, they're recruited because they've got high ALT phos. So slightly different to the Glimmer study where you're recruited because you've got itch and PBC. This is a non-response, and then looking at the subgroup who are itchy and demonstrating further evidence. Now, one of the things that they could then do is look at the proportion of patients who develop pruritus without itch at baseline. So you start off without itch and you compare the seladelpar patients with the placebo patients. Okay, so among patients without itch at baseline, no patient receiving seladelpar developed itch at month 12. Okay, so this is actually just mirroring the adverse event data that that was reported for this clinical trial, where itch was less common as an adverse event in treated patients with seladelpar. This is now looking at the numerical scores that those patients had, and you can see that it sees through. Okay, so again, really impactful and very relevant for patient care in PBC. The other IBAT inhibitor being developed, this is the Vantage study, Professor Cowderley, Mirum Pharmaceuticals, is volixibat. This is a small early dose finding study in primary biliary cholangitis. In case similar to linerixibat in mechanism, it's the idea that you're pumping all your bile acids into your colon, you're interrupting enterohepatic recirculation, and it seems that is then antipruritic. Now, we know that is true from pediatric practice. There are 2 licensed IBATs already in Alagilles and in PFIC. Okay, so this was intriguing data that looked at placebo versus 2 doses of volixibat, and there was evidence of improvement in cholestatic pruritus. This is, short data, small numbers of patients, short duration. From a regulatory perspective, you have to do an analysis of placebo versus treatment for 6 months. You have to demonstrate that there's a difference between placebo and treatment. But nevertheless, another IBAT inhibitor, which is quite exciting for the field, I think. Okay, this then comes back to, is it important in PSC as well? This is the itch PSC. This is data from CALID. Some of you may be involved. It's a consortium for autoimmune liver disease run across the US, focusing particularly on PSC, looking at different quality of life scores and blood tests. Okay, and really demonstrating what we know, but we need this data to demonstrate the value of our intervention. So patient-reported moderate to severe pruritus is common in patients with PSC. I'd say that, moderate to severe is 25% of our population, and it correlates with cholestasis and impaired quality of life. Okay, how you can dovetail that into clinical trials is really hard, because it's these symptoms vary. But again, it's just trying to speak to the importance that we want quantity and quality of life to improve for our patients. Finally, just 2 snapshots of 2 posters to show that there's other efforts to actually tackle fatigue. Okay, now fatigue is clearly multifactorial. Fatigue is clearly a difficult symptom to define. It's clearly a difficult symptom that's not specific to cholestasis, but if we talk to our patients with PBC or PSC or cirrhosis and listen to the impact on fatigue, how it impairs their ability to socialize, go to work, do exercise, okay, we recognize it's a problem. Is it tractable? I don't know, okay? But what's exciting is that there are people who are prepared to do it, okay? This is just early, not intervention data, but galexanolone is an oral negative modulator of GABA receptors, Okay, so quite conceptually makes sense that circulating cytokines are changing what's happening in your brain. Okay, and there's a clinical trial now underway in PBC from Umacrine, where they're actually looking to see whether they can improve fatigue. Very hard and very brave that they take this on because there's so many different factors. Sleep is associated with fatigue, socioeconomics, shift work, stage of disease, but nevertheless, from a patient perspective, it is what patients are looking for. And finally, there's a little bit of data on the holy grail that why don't you treat PBC like an autoimmune disease? We've never treated PBC like an autoimmune disease with success. We do actually know that prednisone, azathioprine can have some biochemical efficacy. For a long time, Roger Williams, the late Roger Williams, believed in cyclosporin for treating PBC. Again, this is a study some of you may be involved in, very difficult, but CMP 104 is something that's supposed to be changing the actual biology of the disease. It's a tolerogenic nanoparticle. So we're getting into much more focused immunological therapies. Okay, this really is demonstrating safety, impact on the immunoregulatory landscape of PBC, but it shows you that we haven't given up completely on treating the disease a little bit more rationally, maybe catching up with our IBD. A long way to go, but important and exciting. And with that, I'll thank you very much for inviting me and look forward to the rest of the last few slides.
Great, thank you. Our next speaker is Saroja Bangaru. She's actually a transplant hepatologist, newly minted, assistant professor of medicine at Keck USC. She comes to us actually originally from UT Southwestern and then came and did a GI fellowship with us at UCLA and then went to Keck to do her transplant hepatology training. Saroja has a very interesting topic today. She's going to try to stump us with some tough cases in autoimmune hepatitis.
Hi, everyone. Thank you for the introduction, and thank you for having me. So I actually modified the title of my talk a little bit. So I'll be going through one case, and my talk is entitled Considerations in Managing Difficult to Treat Autoimmune Hepatitis. So I have no disclosures. And in this talk, I'll review some of the most recent AIH publications, all within 2024, that were noted to potentially be practice changing. And so I'll be discussing the significance and importance of biochemical remission, optimizing the use of azathioprine, MMF versus azathioprine for induction of remission, and then I'll go through some considerations in the management of treatment refractory AIH. So I'll start with a brief case scenario, a 45-year-old woman with non-cirrhotic biopsy-proven AIH. She's been on low-dose prednisone and azathioprine, 100 milligrams, which was about 1.5 mg per kg for 13 months, with inability to wean prednisone off completely due to mild persistent ALT elevation of 50 to 60, and also an IgG elevation of 1900 to 2000. So the first thing to think about is what could the persistent elevation in transaminases and IgG represent? And some considerations include a non-response to azathioprine, non-adherence, insufficient azathioprine dosing, and also that it's not AIH at all, so steatohepatitis. And so now I'll go through some considerations in taking next steps. So when it comes to managing AIH, it's important to recognize that it is frequently difficult to treat, and actually 30 to 40% of patients don't respond to initial treatment, and 15% are intolerant of initial therapy due to side effects. And under standard treatment regimens, up to 70% of patients fail to achieve complete biochemical remission, which is defined as the normalization of both the serum transaminases and the IgG level, just like our patient. So what is the clinical importance of complete biochemical remission? This question was addressed by this study published in Hepatology this year, which looked at the long-term outcomes associated with the lack of biochemical remission. And they used the International AIH Group Registry, which includes well-phenotyped and clinically diagnosed AIH patients. They identified 1,700 with long-term follow-up, and they looked at complete biochemical remission within 6 months. And then of the patients that they identified, 706 had data to determine whether they had complete biochemical remission or not based on the presence of an IgG level. And their outcomes of interest were liver-related death or transplant, and then the development of cirrhosis. So the mean age of the population was 48, and this group was 75% female and 91% Caucasian. About 20% had cirrhosis, and then the mean transaminases were in the 300s, and the median follow-up time was 10 years. And of note, the majority of these patients were on treatment with azathioprine and prednisone. So this slide shows their first main result, which is that the lack of normalization of transaminases at 6 months was an independent predictor of death or liver transplantation with a hazard ratio of 2.93. The other prognostic factors included non-white ethnicity, cirrhosis at the time of diagnosis, and PSC. And the survival curves are shown here, in which blue represents those patients that normalized their transaminases at 6 months, while red represents those that didn't. And you can see that the patients that didn't normalize their liver tests had significantly lower long-term survival at 5, 10, and even 20 years out. So in the multivariable model that included the 706 cases that had available IgG levels, lack of complete biochemical response or remission at 6 months was also an independent predictor of liver-related death or transplantation with a hazard ratio of 5.74. And here you can see that those that lacked biochemical remission, shown in red, again, had significantly reduced long-term survival. So finally, in the analysis that was restricted to patients who had the date of cirrhosis development, a failure to achieve biochemical response within 6 months was associated with the development of cirrhosis during follow-up, with a hazard ratio of 4. And then shown here was that the cumulative incidence of cirrhosis over time was significantly higher for those who lacked biochemical response at 6 months. So these findings support the International AIH Group's statement that the treatment aim in managing AIH should be biochemical remission within 6 months. And it seems that we should be proactive in trying to achieve this. And in the subset of patients with cirrhosis at diagnosis, biochemical response conferred a survival benefit as well. So we should strive for this in cirrhosis patients in addition. 17% of the patients were noted to not have attained biochemical remission at 6 months, but did achieve it at 12 months. And so if there is a lack of response at 6 months, this mandates careful follow-up, but maybe not immediate and complete treatment change if there is some improvement. So our patient clearly failed to achieve biochemical remission. So what can we do to try and achieve it? And is there room to maximize the effect of azathioprine in our patient? As previously mentioned, a substantial proportion of AIH patients fail to achieve complete remission on azathioprine. And for brief review, azathioprine is a prodrug of 6-MP, which is converted to the therapeutic metabolite 6-TGN, and also the toxic metabolite 6-MMP. And variations of thiopurine metabolism can lead to highly variable metabolite profiles and levels. Prior studies have recommended a 6-TGN level of 200 to 450 as being therapeutic, but this hasn't been extensively validated. And in fact, in the guidelines, what's recommended is weight-based dosing, so 1 to 2 milligrams per kilogram of body weight. So this 2024 study by Welsh et al., published in Hepatology, looked at the benefits of attempting to optimize thiopurine therapy. And this was a cross-sectional analysis of 337 AIH patients across 4 European centers. They classified the patients into those who had achieved sustained remission, who had inconsistent remission, and who had never achieved complete remission. There was no difference in age, sex, steroid use, or azathioprine dose. And they measured the 6-TGN and 6-MMP levels in all the patients. So a first important finding was that the level of the therapeutic metabolite 6-TGN does not really correlate with azathioprine dose, although the guidance recommends dosing by weight. And only 42% achieved a 6-TGN level within the therapeutic range, despite being on recommended dosing. Interestingly, the azathioprine dose correlated better, although still only moderately, with the 6-MMP level. So in the cohort of patients who had multiple metabolite levels checked, which included 146 patients total, the 6-TGN level in those who had achieved sustained biochemical remission were significantly higher than the levels in the never remission and the inconsistent remission group. And when these groups were stratified, when these patients were stratified according to the 6-TGN level, a significantly higher percentage of those patients with levels greater than 223 were in sustained remission, shown in dark green. So 66% versus 12 to 19% when the level was less than 223. And they determined the optimal 6-TGN cutoff to be 223, which provided an area under the curve of 0.74 in distinguishing sustained versus non-sustained remission. So the group then explored whether co-administration of allopurinol, which is a xanthine oxidase inhibitor, along with low-dose azathioprine could redirect thiopurine metabolism towards 6-TGN and improve the treatment response. They selected 36 patients who were difficult to treat in that they failed to achieve a stable remission in 3 years, despite more steroid and max doses of azathioprine. And they treated them with allopurinol and a reduced dose of azathioprine. And they compared these to 39 patients who received only a higher dose of azathioprine. And at follow-up, after either azathioprine increase or allopurinol co-administration, there was a much higher 6-TGN level, a much higher increase in the 6-TGN level in the allopurinol group, and also a significant, actually dramatic reduction in the 6-MMP level in the allopurinol group. And most importantly, there was a reduction in steroid use, and also a significantly higher biochemical remission rate of 75% compared with 38%. So consistent 6-TGN levels greater than 222 were associated with higher remission rates. And in this regard, having multiple 6-TGN levels may be more informative when it comes to assessing the therapeutic efficacy of azathioprine in a particular AIH patient. This study affirms the potential role of metabolite testing in those with a suboptimal response, which may allow us to kind of get the most out of azathioprine before abandoning it as a treatment option. And it could also be useful in cases of possible non-adherence and also possible hepatotoxicity. But still, a large proportion of patients did achieve biochemical remission despite subtherapeutic 6-TGN levels, and therefore routine metabolite testing to guide treatment is not recommended at this time. And also there's extremely limited experience with allopurinol co-administration. So it really seems like azathioprine was not working for our patient. So we ought to ask, could this patient have achieved remission with MMF instead? And this 2024 study published in Journal of Hepatology compared MMF to azathioprine. And for a brief bit of background, MMF is recommended as a second-line agent for AIH in the setting of azathioprine intolerance or non-response. But this study compared azathioprine versus MMF in the induction of remission in patients with treatment-naive AIH. And the primary endpoint was biochemical remission at 24 weeks, and secondary endpoints included safety and tolerability. So 70 patients were randomized to receive either MMF or azathioprine along with prednisone, and 2 patients in the MMF group and 8 patients in the azathioprine group discontinued treatment owing to severe side effects. And ultimately, 37 patients in the MMF group and 23 patients in the azathioprine group completed treatment for the full 24-week study duration. So compared to the MMF treated population shown on the right-hand column, the azathioprine treated group had higher transaminases at study enrollment, although they weren't significantly different. They also had a higher total bilirubin and a higher MELD as well. In the intention to treat population at 24 weeks, 56% or 22 out of 39 patients who received MMF achieved biochemical remission, while only 29% of patients achieved remission in the azathioprine group. And this was a 27% difference in remission rate. And in this analysis, the cumulative proportion of patients with biochemical remission was significantly higher over the study period in the MMF group, shown in dark blue, than in the azathioprine group, shown in light blue. And this trend was noted early in the treatment period. And finally, in the subset of patients with cirrhosis, there was no difference in biochemical remission rates, although remission rates were lower overall. And there was no difference in daily, weekly, or cumulative prednisone dose. So finally, it was noted that although adverse events were common in both groups, azathioprine was more poorly tolerated overall and discontinued more frequently. 25% in the azathioprine group versus 5% in the MMF group discontinued treatment due to adverse effects, and 13% in the azathioprine group versus 0 in the MMF group experienced serious adverse events, although it was noted that steroid therapy and advanced clinical baseline may have driven these adverse effects rather than the treatment itself. And in thinking about expanded MMF use, the investigators did highlight a couple of things to consider when using MMF, which is that it is contraindicated in pregnancy and that it does require BID dosing rather than once daily dosing. So an additional brief point is that in potentially refractory cases of AIH, we should make sure that it actually is AIH before making drastic changes to the treatment plan. MASLD is extremely common, and prednisone can cause metabolic syndrome, so weight gain, impaired glucose tolerance, diabetes, hypertension. And so if it would be worthwhile to consider MASH in your differential of persistently elevated liver tests and consider a liver biopsy if felt appropriate. So our patient had failed to achieve biochemical remission within 6 months, actually 13 months since diagnosis. And in this time, she gained 7 pounds and her fasting blood glucoses on routine labs have been 110 to 125, which was new for her. A liver biopsy revealed active AIH rather than NASH. And thiopurine metabolites were checked and the 6-TGN level was 171. Her dose was increased from 1.5 mg per kg to 2 mg per kg daily, and the 6-TGN level was still only 180. Allopurinol was not used. She was switched to MMF, 500 milligrams BID for 2 weeks, followed by 1 gram BID thereafter, and then her liver tests and IgG normalized within 6 weeks, and her prednisone was tapered off afterwards. So for a final few points, in the event that she didn't normalize her tests on MMF, what is available to treat refractory AIH? So there are calcineurin inhibitors, tacrolimus and cyclosporin, which are mentioned in the guidelines and at present are regarded as third-line therapy. But the Taylor trial is an ongoing phase 3 multicenter trial in the Netherlands that's looking at tacrolimus versus MMF in the treatment of those who have failed to achieve biochemical remission after 6 months of treatment with first-line therapy. And their endpoint of interest is biochemical remission at 12 months, and secondary endpoints include fibrosis progression, quality of life measures, and safety. Infliximab has also been looked at this paper published in Hepatology also this year. And this is the largest case series to date looking at the efficacy of infliximab in refractory AIH. So 3,500 cases were screened and 42 patients were identified in whom infliximab was either used for refractory AIH cases or for cases of extrahepatic autoimmune disease. Group 1 was the refractory AIH group, and out of these, all of the patients had active AIH despite prior treatment. In group 2, 6 of 22 patients had active AIH. And so 26 patients total had active disease at the time of infliximab administration. So overall, 78% of patients maintained or achieved complete biochemical remission during infliximab therapy. And of the 26 patients who had active AIH, 2/3 of them achieved biochemical response at 4 to 12 doses. So all 5 of the non-responders to standard therapy, 6 out of 8 non-responders to second-line therapy, and 6 out of 13 or 46% of patients of non-responders to third-line therapy achieved induction of remission with infliximab. The tolerability was good overall, and this was felt to be appropriate efficacy for a fourth-line agent. And both of these things make it attractive in cases of refractory AIH. So I'll just briefly point out that there is analogous data on rituximab in treating autoimmune hepatitis. And this is based on a Spanish registry that spans 8 years. They screened 1,335 patients and reviewed 35 patients who had AIH or variant forms and were treated with rituximab. It included people who had refractory AIH or comorbid autoimmune or hematologic disorders. And in this cohort, rituximab led to complete biochemical remission in almost 90% of the patients, and also a significant reduction in steroid use in most patients. So in conclusion, in managing AIH, early biochemical remission is a goal in both cirrhotic and non-cirrhotic patients and improves long-term outcomes. You should consider checking thiopurine metabolites in azathioprine non-responders. You can consider MMF upfront. It seems to achieve early remission more frequently. And then we can keep CNIs, infliximab, and rituximab in mind for our difficult to treat cases. Thank you very much for your attention.
Our final speaker for the meeting is Amandeep Sahota. Dr. Sahota is the National Medical Director of Transplant Services for Kaiser Permanente and a clinical professor at the new Kaiser School of Medicine. And she's here to talk to us about an interesting topic that we came up with called Myths in Hepatology.
Thanks, Steve. Thanks, everyone who are still staying. So myth busters is what I will start by saying the topic is. So no financial disclosure. We're going to be talking about medications which have myths. We have myths regarding imaging, viral hepatitis, ascites, encephalopathy, and so on and on. So let's get going with these myth busters. The first one is on medications, and I think the prior speakers did talk about some of them. So the first one is the first myth. Patients on statins should have liver tests monitored for hepatotoxicity. I think we all, in 1980s, when the statins first emerged, the recommendation was that the liver test needs to be monitored. And today we have 7+ statins in our market. And just to give a background is that there was an elevation of liver test noticed in 10% of the populations when statins were first introduced, and 1 to 3% had 3 times upper limit of normal. But now with all the statins and the data, 2012, the FDA modified the product label of statins. Baseline liver tests are needed, but you don't need to follow up the liver biochemistry unless clinically indicated due to low risk of hepatotoxicity. So, our primary care physicians and, they are still sometimes practicing and asking if liver test needs to be monitored. So that's the first myth buster. The second one we talked a little bit today is should we use statin if somebody has liver disease? And AASLD practice guidelines 2022 did mention that it's okay to use statins in compensated chronic liver disease patients with cirrhosis. And we heard about it this morning about people with decompensated cirrhosis. You can individualize based on the risk benefit the use of statins. Again, the routine on-treatment monitoring for liver biochemistry is not recommended due to low risk of hepatotoxicity with patients with liver disease. But if it's clinically indicated, we should follow the liver test. So that's the second myth. We talked a little bit about how important that this point is, because sometimes our patients with our fatty liver patients are not given statins because the clinician is concerned about hepatotoxicity. So this is another important point that we have also data on a retrospective large observational study with hepatitis B and C patients where we saw the benefit of statins by decreased progression to cirrhosis, episode of decompensation, overall mortality, and HCC in some cases. Timolol, I think we all heard this morning from Elliot about pain. Pain is quite common, and we really need to make it sure that liver disease patients should be given acetaminophen if it's indicated. The pharmacokinetics changes has not led us to have a clinical adverse event if the dose is kept under less than 2 grams a day. So it's okay to use acetaminophen in patients with chronic liver disease, compensated decompensated cirrhosis, and even in post-transplant patients. I still get a call, is it okay to use Tylenol in my patients who are post-transplant and having pain? Another myth is metformin can cause liver injury. And I think also metformin doesn't, that's one. And the other one is it can cause metabolic acidosis. And it has been only reported out in some case reports. So no need to withhold metformin from patients who have abnormal liver tests. No routine monitoring of liver tests is needed before or during using metformin treatment. So that's another myth. Sometimes our patients with MASH need metformin, and even our obesity medicine colleagues are asking us, is it okay for me to try metformin? Go for it. If it's indicated, we should use metformin. The reason of doing this talk is because there's so much restriction put in on our liver patients. So I always go to liver talks. I think most of you are aware of this website developed by National Institute of Diabetes and Digestive Disease, Kidney, where you can put the information on the medication and see if, what's an update. Imaging mythbusters. So there's we talked about medications, but also imaging sometimes. Non-contrast imaging, is it appropriate for patients with liver lesions? And when you see a patient who has a liver lesion, you really need to know what that liver lesion is. So contrast imaging is needed. For example, CT 4-phase or MRI. It's crucial to characterize what kind of lesion it is. And I think one of the things which we all recently, it's a myth buster now, so I will say that, we are in our patients with chronic kidney disease where we were using a lot of MRIs. And then there was a warning regarding incidence of nephrogenic systemic fibrosis. So just wanted to clarify that myth that, the incidence of that is very, very low. It's less than 0.07%. And that also is type 2 gadolinium-based imaging. Type 1 has already, nobody's using a type 1 type of contrast in US, but it's type 2, and especially patients who are chronic kidney disease stage 4 and 5. So it is okay. And right now, it's not like you have to, I normally talk to my patients, let them know that it's a very, very small chance. And, in the past, we were asked to consent these patients. Yes, it's always good to have a shared decision making, but when you have a liver lesion and you really need to know what it is, you need a contrast imaging. Simple cysts are common. They can be incidental finding. And if the patient is asymptomatic, you really do not need any intervention or follow-up surveillance scans in asymptomatic patients. So sometimes we get this consults and, we're like simple cyst. Really, if the patient is asymptomatic, we really don't need to go further. Viral hepatitis, I think we all know in this meeting, we have talked about viral hepatitis C. So just wanted to bring it back again that hepatitis C treatment should not, this is a myth, should not be considered during active substance abuse. And in 2018, the IDSA and ASLD guidelines said that the recent active injection use or alcohol use should not be considered as an absolute contraindication. You want to make sure the patients are given access. They need to be compliant with the treatment, but that should not be, if you can work with addiction specialist and you can have a real good discussion with the patient, this should not be, the treatment for Hep C should not be withhold from this patients who are actively using substance or drinking alcohol. Chronic hepatitis B and C pregnant mothers should deliver via C-section. That's a myth. Clinicians who are taking care of hepatitis B and C pregnant women, unless and until there's another indication to do a C-section, just for hepatitis B and C, it's not indicated that they should go through C-section. And studies have shown that there's no impact in reducing the risk of being infected with hepatitis B or C in infants. So, no need to do C-section if somebody has no other indications to get a C-section. Hep C and Hep B mothers cannot breastfeed their newborns. That's a myth. It's safe to breastfeed in mothers with Hep C and Hep B. Make it sure that the newborn has proper immunoprophylaxis against hepatitis B. And, you have to also make it sure that there's no other cracked nipple or bleeding, and that's leading to that transmission. Otherwise, it's okay to breastfeed. Ascites. I think this is a myth. No fever, no SBP. Well, we know from our EASL and AASLD guidelines, independent of the symptoms, a diagnostic paracentesis is recommended for all patients with cirrhosis, new onset ascites, patients with ascites who are hospitalized, signs and symptoms of peritonitis, signs and symptoms of infection, any AKI encephalopathy, worsening MELD sodium or MELD 3.0. So a teaching point is that the patient is not feeling well, patient is seen in the hospital, it's important to rule out SBP. I still hear that folks say that there's no fever, so I did not really tap the patient. SBP may be asymptomatic, especially in outpatient setting, and ascites fluid. Every time when we take the fluid, it's important to test it, both in the inpatient and the outpatient setting. In the hospitalized patients, delayed diagnostic paracentesis sometimes is associated with almost 2.7-fold increase in mortality. So very important. So it's not like in the middle of the night that, you were just like, I'll just tap the patient in the morning. It's an important, you could delay the care. Myth 11, Mythbuster, single dose of antibiotic does not affect the cell count. Well, I'm married to an infectious disease doctor, so this is very clear to me that one dose of antibiotics can affect the cell count. It's known that obtaining cultures during antibiotic therapy is associated with significant loss of pathogenic detection. Therefore, diagnostic paracentesis should be obtained prior to administering even the first dose of antibiotic. And this is something we really need to talk to our ER doctors, because everybody who is liver patient gets a CT scan by the time you see them in the morning and an antibiotic dose. So really important that if you're thinking you need to do paracentesis, send the fluid for cultures. Myth 12, paracentesis is not needed to assess the resolution of infection. With still everyone who had bad SBP, we should repeat a paracentesis at day 5 and, do check that the antibiotics the patients are on is really helping them. We are seeing a lot of resistance these days with antibiotics. So it's very important to make it sure the patient is on the right treatment. SBP can be treated, treatment can be performed as an outpatient. It could be controversial, but is an outpatient treatment plan safe and achievable? I think that the guidelines still are recommended that initiation of empirical IV antibiotics immediately at the diagnosis of SBP. There's no clear consensus on hospitalization for duration of SBP treatment for 5 days, but we all treat our patients for 5 days, especially asymptomatic patients. Rationale is that if the patient is hospitalized, you can also monitor these patients for hepatorenal syndrome and also follow their MELD score. So at least I'm lucky that in KP, we do have lots of resources where outpatient infusions at home care can be delivered for patients. They don't need to be hospitalized, but they can definitely complete their IV treatments for 5 days. Encephalopathy. Elevated ammonia, encephalopathy. Well, that's not true. Your measurement of ammonia level can be elevated and patients might not be showing any signs of encephalopathy. And patients can have grade 3, grade 4 and can still have normal ammonia or mildly elevated ammonia levels. So just elevated ammonia does not mean it's correlation with encephalopathy, portal systemic encephalopathy. So increased blood ammonia does not correlate. Sometimes we do have patients who, for some odd reasons, their ammonia level is checked and they are coming to us for evaluation. Well, if there's no signs, then it doesn't mean much. Trending ammonia level, is it useful? No. Basically, you can keep trending. Sometimes somebody writes a standing order for ammonia and the patient is completely awake and alert. So you don't really need to see, even in encephalopathic patients, a normalization or a decline in ammonia level. So no use of using ammonia. Coagulopathy. Now, this is a little controversial topic, as some of you are gastroenterologists, but in the hepatology world, don't use INR as a sole predictor for procedural bleeding. And paracentesis is a low-risk procedure, so we don't really check INR or platelet count. But high-risk procedures where you are really doing sphincterotomies or you're doing peg placement or something really tips. That's our high risk condition. But just EGDs and variceal ligation, colonoscopies, ERCP without sphincterotomy are still considered as low risk procedures, where you really don't chase INR. So the societies are recommending that, definitely AASLD has no stand on platelet count, INR, or fibrinogen, but we do have interdisciplinary care for our patients. So our radiology, interventional radiology society has platelet count more than 30, INR less than 2.5, fibrinogen more than 100. And then our GI society also has for procedures, for high-risk invasive procedures, platelet count more than 50, no correction of INR, and fibrinogen more than between 120 and 150. Do not give anticoagulation in patients with cirrhosis. I think we know more and more about it, that there is role of anticoagulation in our portal vein thrombosis patients, and it's potentially improving survival and also reduces hepatic decompensation in patients with cirrhosis. So this is a myth. In the past, we were like, no, please don't give anticoagulation with patients with cirrhosis, but more and more benefit has been shown in cases of portal vein thrombosis, help of anticoagulation. HCC. So a myth is only cirrhotic patients need to be screened for HCC. We know hepatitis B without cirrhosis, you can still develop HCC. So that's something to keep in mind. And hepatitis C patients who have received sustained virological response, no need to screen them for HCC. Advanced fibrosis patients, please don't forget them. They still need to be regularly monitored for HCC screening. I just added hemochromatosis is not a common condition, but sometimes we do get this myth. Elevated ferritin, hemochromatosis. Just wanted to put it out there. 10% of the patients in primary care clinic can have elevated ferritin because of many other reasons. So obesity, fatty liver, daily alcohol consumption. So it's not that you have an elevated ferritin, it's hemochromatosis. And then also old thoughts, we still have physicians who are talking about Brown's diabetes and say, if you have that population screening. And so it's better just to keep in mind that diabetes and hemochromatosis can be multifactorial. It could be insulin resistance, not just all related to hemochromatosis. Patients with hemochromatosis should be put on low iron diet. Decrease in iron dietary has not shown that decrease iron stores in hemochromatosis patients. So all foods can contain iron and most patients will absorb small fraction of iron. You should just avoid iron supplements, alcohol, and uncooked seafood. Especially to tell somebody, don't take iron, and so then people can just not have, get so fixated on the food. Liver transplant, I think Jeff talked about it yesterday. I think indication of liver transplants are exceeding. And I think one of the, a couple of years ago, we all got so many talks on alcohol as indication for transplant, but is a negative blood alcohol test rules out active alcohol abuse. And I just wanted to put out the use of PET. I think it's a biomarker which has really changed the way we practice and follow our patients. We know that blood alcohol concentration is only good for 12 to 24 hours. ETG urine test is up to 3 to 5 days. So PET test is very helpful, especially if we want to also see if somebody is having low consumption or excessive drinking. So that has been quite a game changer biomarker. Interestingly, this was first discovered in 1984, but it just got commercially available in 2017. So, it's interesting that we had such an important biomarker available for us for a long time, but just recently, because of our liver transplant change in criteria, it's been more widely available and being used. We all know first decompensation patients are eligible for liver transplant. So all alcohol hepatitis patients are eligible for liver transplant. I think I still understand that this is a myth. Not everybody is eligible, but I think a lot of the message gone out to the community is everybody's just eligible. So that's why we all are getting calls about patients who are still actively drinking, be considered for transplant. Still remains first decompensation, favorable psychosocial profile, and good psychosocial support. Transplant patients of alcohol have low risk of recidivism. I think more and more data is coming. I think we got lucky that we had Brian's group able to tell us about this topic. But I think as we are looking into this patient population, we are seeing that our transplant patients, whether they had alcohol liver disease or non-alcohol liver disease, I just recently looked at our data, people are having high risk of recidivism. People are drinking. And as the time passes by from the time of transplant, there is more and more alcohol use happening. Liver transplant indication is limited. I think it's a myth. Liver transplant space keeps on expanding. We heard about alcohol hepatitis. We also heard about intrahepatic perihilar cholangiocarcinoma. I think the new kid in the block right now is colorectal liver mets as an indication for transplant. So this transplant world is not limited anymore. It's really expanding and really helping many more patients. So I think that's were the 27 myths. I hope it was helpful. This all started with our Fred Simmons rounds, which we do with our fellows. We pick up topics, and this was the fellows who came up with all the myths that they were thinking that existed. So it was nice to present their work today. Thank you.
I'd like to have the previous speakers come up for a panel discussion in addition to Jasleen Singh and Irene Vodkin. So this should be entertaining. As I was listening to Dr. Sahoda's talk, I started to have PTSD because all of these myths account for like 95% of all our hepatology consults that we get. Yeah. So we'll just get into the questions. Lupe? Oh, the microphone is it?
Can you hear me?
Yes.
So thanks for the presentations. They were great. I have a comment. I just gave it at the ASLD. I gave a talk as to should we correct coagulopathy before procedures? And my bottom line was no, not even the platelet count. Like you said, the INR, so there's this huge study by Nick Intagliata that had like over 3,000 procedures. Only patients that had with cirrhosis had procedures, less than 0.05% actually had a major bleed. And their baseline INR, platelet count, whatever, had nothing to do with the bleed. It had to do with how bad the procedure was, if they had AKI, I forgot what the other thing was. But the bottom line is that in the patient with cirrhosis, even if they're really decompensated, that they have both an equilibrium with prothrombotic and anticoagulant, it is balanced. So the patient with cirrhosis, even decompensated, has the equal probability of getting prothrombotic than to getting antithrombotic. So in the platelet count, so we did a study with Erika Vila, and you could see the patients who bled, whether they got the replenishment with whatever you wanted with FFP or with whatever, they would still, the only patient that bled was one patient who had AKI. And I think AKI is the main predictor of bleeding because it affects the platelet function. So I would vote that you do not have to correct any coagulopathy. You have to make sure that the patient does not have AKI, is not infected, so that you are correcting the platelet themselves, not transfusing platelets is going to do nothing to minimizing risk of bleeding.
Remember, Dr. Reynolds always used to tell us they may have fewer platelets, but they're super platelets.
Well, they're not super platelets, but they're equally, but they're balanced. The pro-hemostatic and the anti-hemostatic are totally balanced. And this is a study that we did with one of our fellows, Alberto Saneto, who did a great paper that's published in Hepatology. So they're not at a higher risk. They are at higher risk if the platelets are not functioning exactly. If you give them AKI or something like that, then I'm more afraid of AKI or infection when if I'm going to do a procedure. Yeah.
Thank you. Kelvin.
I have two questions for Dr. Hirschfield. So the first one, for patients with PBC and you need to do an EGD and you see varices, would you prefer banding versus beta blocker in this situation? Second question, if you have the availability of both seladelpar and elafibranor, and cost is not an issue, which one you would choose? I mean, I heard there's some data on improved fatigue with seladelpar. And are you gonna be biased against the other drug because you did research on seladelpar?
Sure. I mean, to the first question, I think our practice around portal hypertension and PBC actually follows the guidelines really, and we use a lot of beta blockers. And we don't actually deviate particularly in terms of how we manage it. I don't see very much pre-sinusoidal portal hypertension in clinical practice anymore. I know it exists, but actually in practice, in fact, there have been data. The vast majority of patients with PBC who have varices are cirrhotic. Okay, so I think you can use, FibroScan, platelet count, and we're using a lot of carvedilol, and then banding is really after that.
I think just to clarify, these for non-cirrhotic PBC.
But we just don't see it. So with effective treatments, we're not seeing very much pre-sinusoidal portal hypertension anymore. I can't remember the last patient in 5 years that I've seen with PBC who's run into problems. So I recognize it. It happens. It's to do with the fact that inflammation is very much around the portal tracts, and then patients with PBC do get more inflammation, portal phlebitis essentially, and that raises their portal pressure. But with increasingly what you're seeing in practice is well-treated patients. So and also the non-cirrhotic portal hypertension in PBC will still have a big spleen, will still have a low platelet count. They've still got portal hypertension. I think the question is a sort of a devil's question really to ask me to say, will I tell you which drug is better than another? We're going to have to wait for real world evidence to see how second line therapy is being applied in practice. The way I tackle it is I'm looking for drugs that meet my intuitive targets, and my intuitive targets are normalization, and my intuitive targets are symptoms. And then, it's difficult to do head-to-head comparisons of phase 3 trials. It's always hard, everyone wants to do that, but the true comparison is when you do it in the same study. But the two trials are essentially identical in terms of inclusion criteria. The populations are essentially identical. You can see that from baseline ALT phos. You can see that from the proportion of patients with pruritus. And then what I tell clinicians they should be doing is trying to think about certainty. So they're going to start a drug for a chronic disease. They want to choose that drug with the highest certainty it's going to reach their intuitive goals, okay? Their intuitive goals of normalization and their intuitive goals of improving pruritus. And then it's for them to interpret the two phase 3 trials to say which of those two drugs gives them the highest intuitive likelihood of reaching those targets of normalization, okay, and improvements in pruritus. And then time will tell whether or not, those comparisons. So seladelpar, 25% normalization, elafibranor, 15%. Seladelpar has a clear impact on pruritus in the key secondary endpoint. Elafibranor demonstrates effects on pruritus only in secondary analyses. And then finally, safety and ease of use and drug interactions will become relevant. So, I think what we'll see is more and more real world data, and it we'll learn, how to use these drugs in practice.
Thank you.
Jeff?
Yeah, comment on a question. Our rheumatology colleagues know that there's an increased carriage of HLA-B 5801 in Asians and Asian Americans, and which increases a significant risk of dermatopathies, like toxic ones. And we actually had a Vietnamese American young man who was placed on allopurinol, and which actually causes this problem, and ended up having a liver transplant. He had acute liver failure with DRESS. So I don't know if anybody's using allopurinol in AIH, but If anybody was going to, especially.
No, never. I
Southern.
mean, so I like your data. It's a very good review of the literature, but it's so fiddly. I can't control that they'll come back for blood tests. I'm worried exactly about heterogeneity of drugs. So, you know, it's a great theory to use metabolite monitoring and to then use allopurinol and shunting. But in practice, can you do it safely and feel comfortable to all the different things you just pointed out? So I've never done it because it doesn't seem to reflect real world practice, at least not my real world practice anyway.
Just as a caution. And my question though, atorvastatin. So I don't know about others here, but I've seen a fair amount of either autoimmune hepatitis like liver injury or actually patients that ended up with autoimmune hepatitis that needed long-term immunosuppression. The question is whether we feel that atorvastatin should be avoided in our patients or if any different type of monitoring should be done.
Does anyone have any comment, any experience?
To your first question, I think I've not used allopurinol, but I think CellCept is I'm really picking up. Maybe being a transplant hepatologist, I'm very comfortable with CellCept and adding allopurinol. So I think I'll be very careful with that too. I really don't know the answer whether, we need to really do more monitoring on a typical type of, which typical type of statin we pick. But, working in Kaiser setting, we have a preferred agent and that's what's been used. But in my liver patients, sometimes pravastatin was something which we were really using in our patients.
Thank you.
I know that we had said not to check for liver tests while on statin drugs. But of course, our colleagues, I mean, statins have such stigma. And so they always ask us, well, can you give me a level that I should be concerned about? What do each of you tend to advise? Mark?
Definitely recommend that they not routinely follow levels of the LFTs. And again, frequently the levels will normalize even if they have the transient elevation. I tend to counsel them more about the myopathy, especially in my cirrhotic patients. I've definitely seen a lot more patients who have cirrhosis and heart disease and have intensive statin therapy get in trouble with myopathy over actually getting in trouble with liver test elevations. So I tend to counsel the patients and their physicians more on that aspect.
So you tell them, don't check liver tests.
And if they do, again, 3 to 5 times the upper limit of normal, they can talk to me.
Dr. Hirschfield?
Yeah, I try and discourage them at all from measuring liver tests in the statins. And I think I would also use a relatively high threshold. Whether they listen, I think is a totally different story. But I mean, we all know that there's so much background fatty liver and so much fluctuations in those liver tests. I just remind them of the leading cause of death, okay, which is cardiovascular, and that there's a good cogent case that we should all be, we could all be on statins, in terms of outcome and a linear association with total cholesterol. So I really try and highlight to them that they're doing the patient a huge favor, let alone the benefits they're getting from their liver disease in terms of reducing cardiovascular risk.
Any others? Any other comments?
I agree with everyone else. I think it's a scenario that we commonly run into where someone has elevated liver tests after initiation of a statin, and then the PCP actually discontinues the statin. So, it's a little unfortunate to not have patients get that chance to see if their liver tests will normalize. So I try to discourage other providers from checking liver tests.
Do any recommend not to check liver enzymes and simply just to look for jaundice as being the sign of, isn't that the recommendation for INH? Don't check enzymes, just check for jaundice?
No, I think if the patient is having symptoms, then LFTs get checked. So you don't wait for jaundice, but I feel like, if they are having myopathy or something, the liver tests are getting checked. Having a baseline, I just want to make it sure we need to have a baseline. Sometimes that's the problem that, baseline is not checked and then somebody checks a liver test and then you are like, what is the baseline? So I think if we really need to focus on is the baseline and the symptoms. And, again, you don't want to be too late, but I think there are many reasons that we need to know the baseline, and then we need to make it sure that there's a benefit of using statins and not to have anxiety.
Chuck, I think was.
Two comments about paracentesis. 50 years ago, we showed that immediate inoculation into blood culture bottles increased recovery rates by 20 to 30%. And it still goes on true today, even with the newer blood culture systems that we use. And you got to argue with your, people in the ER. You got to argue with the people in interventional radiology because they just want to send it off to the lab, and it drops your recovery rate. The other comment is, particularly with IR, you can put a 22 or a 25 gauge needle into anything, and they're not going to bleed out. Their platelets are 45,000, but you need that fluid, and it's very simple to get 10 cc's out, dump it right into a blood culture bottle, and you're good right there and then.
All right, one question and one comment, but I'll do the comment first. If you could add to the myths, Amandeep, that AST and ALT are liver function tests. They're liver enzymes, right? The question for the panel is mycophenolate levels. I've been using budesonide, mycophenolate, and urso triple for all my autoimmune patients. Nobody's gone to transplant. Nobody's progressed using FibroScan annually. There's a good paper in Japan that urso alone can be used for autoimmune hepatitis. It's a relatively small number of patients. And then mycophenolate levels were published by Roche in the solid organ transplant field more than 2 decades ago. Target level 1 to 3.5. I've had nobody fail mycophenolate. So I think that's something we could add.
I think, Bob, those points are fair, but I think one of the challenges in autoimmune hepatitis really is that there's a huge spectrum of disease. And, you've really got this whole range from mild, moderate, and severe. And really, it doesn't matter what you give your patients with mild to moderate disease, so long as they take it, and as long as the prescriber uses it carefully, it will work. So most AIH, in fact, will respond if the patient tolerates the drug and they're adherent. And so that's why, I like your approach, but I'm not sure that it's necessarily what it's really reflecting is expert care. Okay. And the biggest gap in AIH is the lack of expert care and the lack of the fact that it's a chronic disease where you've really got to think about your, decades and decades of treatment. So, I always find it very difficult to then do these comparisons about which drugs to use, because it's very hard to subtract expertise from adherence, from tolerability, because the true patients with, difficult AIH, because it's very potent, very rare, okay, in fact. And that's why if you look at the different data for second and third line treatment, what you see is good data for tacrolimus, good data for cyclosporin, good data for mycophenolate. It's okay if you give Rituxan, you give anti-TNF, because a lot of the time the reasons they were in the study was not because they had difficult AIH. They didn't take the medicine. They don't like steroids. That's the bigger point, is that steroids are bad. And patients don't like steroids. It rots their bones, it rots their skin. Okay, it gives them a poor quality of life. And that to me is the bigger picture in AIH. So, I think the data on MMF is really interesting, because what it tells you is it's just easier to use, and it's not that it's better, but if it's easier to use, then that's good for patients ultimately.
Sorry, John.
And I think at that time, the patients are getting expert care by the time they reach third, fourth line. But I wanted to we had a couple of cases recently where, because people were getting high dose steroids, so they were put also on Bactrim, all those other prophylaxis. And when we biopsied that liver, we were like, nothing is working. It was drug-induced hepatotoxicity. So I think also to keep that in mind, that as we keep going on these complicated AIH pathways, that there could be some simple things, whether adherence is one, or it could be drug-induced.
Remember, the average age in an AIH cohort is 50 to 60. So this concept, that all these young patients, they're a very important subgroup. But if you actually look at the epidemiology of autoimmune hepatitis, our average age of the people we're treating is 50 to 60, and we need to balance risks and benefits. and look at their real outcomes, cardiovascular, cancer. So I like the data on normalization. We published a similar paper from the Canal Study Group, but I'm not slavish to it in AIH because before you know it, you're giving drugs that you didn't need, and actually it's the toxicity that you're treating, not the disease.
And 25% of these patients have metabolic syndrome, so it gets really messy.
Molly? Just a couple of comments on paracentesis for SBP. So if we have a culture result showing sensitivity to the antibiotic, we don't need to repeat the paracentesis, and it's in the guideline. I agree with you that if we don't have culture, repeating it is indicated, but it shouldn't be a blank statement in my mind. The second question for autoimmune hepatitis, everybody is moving on the CellSAP there now, but CellSAP has side effect, and monitoring the cytopurine metabolite level is important, not just for the 6-TGN, for the 6-MMP, because bone marrow suppression is one of the major toxicity of the drug. And in a patient with advanced fibrosis, using CellSAP is a little bit tricky. We need to monitor the CBC quite carefully, and it has to be with a differential.
I think point is well taken, but most of the time people are just sending cell count on the ascites fluid. That is the gap we are having. Cultures are not done properly. They are not, so that's why, treating somebody who's decompensated for 5 days and repeating if they are not getting better.
Question.
Okay. I had a challenging case of a cholestasis, a 30-year-old Hispanic female. No symptoms, no pain, no pruritus. Liver enzymes were high. Bilirubin was 20. ALK-Phos 190. AST, ALT in the less than 200. Okay, so we did a hepatitis panel, all viral hepatitis serology negative. Did ANA negative, AMA negative, MRCP, no biliary dilatation. So ended up doing a liver biopsy. It says cholestasis, but no inflammation, no fatty changes, and no cancer. Okay, so is this a new entity I should be aware of? Here's a handout for this meeting. It says progressive familial intrahepatic cholestasis. I think it's an advertisement for the genetic testing for this kind of disease.
For sure, you should do genetic testing for that kind of patient, because that sounds like either a DILI, and a proportion of DILIs are, expressed if they've got genetic cholestasis. So if you have a truncating mutation in BSEP, for example, and you take northisterone, you'll get a pure cholestatic syndrome. Okay, and then the variety of drugs that someone could take is endless, endless and endless. So that's how pure cholestasis, that sounds to me like DILI, most likely. Okay. And then, I'd look at the gamma GT to see if the gamma GT was elevated or not elevated. If it's a low gamma GT, then your yield for a cholestasis gene panel through prevention genetics goes up. But even doesn't mean that, you may not pick it up on that panel. It's only the known variants. But that to me sounds like a DILI plus or minus a genetic predisposition.
Okay, what is the treatment for that? So IgG4 is the diagnostic test for that.
No, the diagnostic test would be a genetic test.
Genetic test.
Yeah. So it's actually quite interesting. If you're brave enough, some people would give rifampin. Okay, rifampin there's a hepatosecretory failure syndrome where rifampin actually works quite well in those patients, but it takes a very brave hepatologist to give a patient with a bilirubin of 20, rifampin, because of the concerns of toxicity. But actually rifampin will speed up the clearance of cholestasis. The truth is you have to be very patient. She's got no liver failure. She's cholestatic. With a bit of luck, she's not going to end up needing a transplant. She'll get better. But, trying to dig into what was the environmental trigger, that can be difficult.
She had a liver size of a 15 centimeter. Can fatty liver ever progress to this state?
You also said GGT. I think I like the idea. Do you have a GGT on that patient? Because that is the easy cheap test before going into the genetic
That was elevated, like AST, ALT.
GGT was elevated too.
Oh, two.
But it still sounds like DILI is the most likely, and it's very common.
That's what we are thinking, that drug induced.
I just want to make a comment that we see something like that not infrequently. A lot of times these people are taking herbs, over-the-counter medicines, and that has to be identified. That's very important to ask them what they're taking. Something they are taking for constipation. You know, it's not uncommon.
Yeah, this
And if the
patient had
INR
no
is
alcohol
normal, if the
denied any
INR is
early
normal,
use.
well, if the INR is normal, I think like the comment from here, she should get better, I think, hopefully.
I've got a guy at the moment who did stanozol, you know, and he's been jaundiced now for 5 weeks. He's annoyed that his jaundice is slow to resolve, but you know, he used stanozol for a month from bodybuilding, and now he's going to be icteric for a few months, isn't he?
And by the way, a lot of
Only
these
say 1
herbal
year.
medicines are mislabeled also. These are mislabeled, like they will have something and you would not even know what is in them. Sometimes they're mislabeled and they're also contaminated sometimes, like with the anabolic hormones. And one thing I wanted to mention, you know, I'm obviously a community gastroenterologist. I would not take a 2 centimeter polyp out in somebody with liver disease. And so I don't think we should blanket and say that don't correct platelets and INR. I agree for paracentesis, definitely you should not do it for routine endoscopy and colonoscopy. But if you're going to do an ERCP or you're going to remove a big polyp, I would be very careful to correct it. I don't know what the panel say about that.
That's why I mentioned in that slide. Otherwise, I was with Lupe, don't bother, you know, but I knew that the audience is going to have gastroenterologists. So I put GI, IR recommendations. So
Easy. I wouldn't take it out, but I'd ask you to take it out. So that's simple.
At UCLA, we also use Doptelet. I think that's avatrombopag. And that's, are you, Dr. Garcia, is that you're saying? Oh, for platelets, when the platelets are low. Are you, Dr. Garcia, is that, are you not,
I'm not a fan. I mean, you may improve hypertension, for example, or other stuff like that. But really, the evidence shows that even though I understand, so I don't do procedure, I think I would be scared, like if I put down 30K, right? And maybe you cover yourself and you do it, but the evidence shows that it really has nothing to do with what the baseline.
Evidence is for ERCP and sphincterotomy and large polyps.
Yeah, for everything. Yeah, look at that. Look at Intagliata. Major procedures were in fact related to bleeding, but it had nothing to do with their baseline coagulopathy. That's the whole thing.
Why aren't you using Lupi, why aren't you using thromboelastography? TEG is fantastic.
But it doesn't, well, that's our study with Erika was we're doing TEG versus, you know, regular FFPs and blah, blah. And at the end of the day, of like 50 patients, 25 in each group, 1 bled, and it was in the FFP group. And the problem with this patient had a creatinine of like 12.5. Do you see? So there are other things that make you have, although you may have that low platelet count, they have a higher propensity because of additional things like, or they're clearly they're an anticoagulants, you take them off of them, you know, but if there's an infection or an ACAT, you try and correct those and then you do the procedure. But I hear you and I understand, but maybe doing some other correcting some other of the other coagulation factors would be better than giving the, I'm totally against FFPs for sure. I think that is terrible.
The problem, they develop antibodies, you cannot get that platelets again. If I'm going to do an advanced procedure, like doing a PET tube or doing an FNV or doing a sphincterotomy, I would correct it. I personally, I would have to see the evidence.
Look at the evidence.
So Dr. Garcia, when are you going to use avatrombopag then? In what situations? I mean, I've used it a few times. I mean, like patient having big surgeries, for example, like spinal surgery. I actually have one right now. I just ordered 2 days ago because she's going to have a heart valve surgery coming up. So I mean, it's hard to convince the surgeons when they actually say, I'm not going to touch the patient until platelet is above 100.
And I hear you. 100 is not
Yes,
that incredibly
particularly
low.
100. It's actually, that's a stretch. There is another surgeon actually asking for 150. I'm like, no way, it's not going to happen.
So I can say whatever I want. If the one that's doing the procedure wants it done, I mean, there's no option, right? I can tell you what the evidence shows, but it's hard to convince someone. And if I was probably doing a procedure, 100, I think is actually a pretty good platelet count.
Yeah, I mean, AVA thromboback is great. I mean, I did a trial on this particular patient. It went from 50 to 125, and on day 12 after taking it. So it works.
So you don't know? No, it works. 100% it works in raising the platelet count. Whether it decreases bleeding risk is the question. You see? It's a placebo for the doctor.
Yeah, it's the number. It's a number.
It's a number that exactly.
But I think large polyps, sphincterotomy, it comes into the high risk if you look at the table. So, yes, I did put the AGA guidelines there for INR correction. I think more needs to be known, and I think at this time, this is how we practice.
Well, that was actually very entertaining. Thank you.